Um, I'm Gautam Nayak. I am the Washington ACC governor, and this is day 2 of our 2021 annual meeting. Just wanted to again thank Liana Collins, our chapter executive, for all of her incredible work over not only over the last 24 hours, but obviously over the last year, putting all of the pieces together for us to have a successful meeting. Day 1 was fantastic, and I think day 2 is going to be even better. Wanted to also thank Richard Chang and Lane Bennis, our program chairs. I'm going to turn it over to them after our keynote address, but really honored and excited to have Dr. Dipti Itchapuria, our current ACC president, here with us today to give her keynote address. Dr. Itchapuria is the program director of disease management for the Jeffrey Carlton Heart and Vascular Institute in Orange County at Hoag Hospital. It's a position she's held since 2001. And she is also the Eric and Sheila Sampson Endowed Chair in Cardiovascular Health. She actually is also leading the Congestive Heart Failure Management Program and the Anticoagulation Clinic at the Vascular Institute, which is Orange County's highest volume, highest rated cardiovascular program and one of the most preeminent cardiovascular centers on the West Coast. Dr. Itchapuria received her medical degree from St. Louis University School of Medicine and continued to complete her residency in internal medicine at Stanford University. She then joined the general medicine faculty at the University of California, San Francisco, and did her cardiology fellowship then at Georgetown University and her interventional cardiology fellowship at Stanford. She's board certified in cardiology, interventional cardiology, and nuclear cardiology. She's an outspoken advocate for building greater awareness about cardiovascular disease, as well as cardiovascular disease in women. She has been conducting all kinds of community lectures in California aimed at education for her patients, and she's co-authored a number of different scientific papers, as we all have probably read. Most importantly, she does the absolute best interviews on Accel. So if you have not heard her interviews on Accel, which have inspired me over the years, you need to listen to them. Even the older ones are great, always through the lens of a practicing cardiologist, which I've appreciated. So with that, I'm really honored and excited to introduce Dr. Itchapuria, who has kindly joined us today despite her busy schedule. And she's going to be talking about digital transformation in healthcare. Thank you so much for joining us.
Thank you so much, Gautam. It's such a pleasure to be here with the Washington chapter. And I want to thank you, Liana, as well as the program chairs, Dr. Chang and Dr. Bennis, for having me here. And I'm going to go ahead and share my screen so that we can, let's see. I'm sorry. Hold on.
You can see the screen. It's just not in the presenter.
There we go.
Yep, there you go.
Perfect, perfect. Okay, so what I thought I would talk to you about this morning was digital transformation, the quintuple aim, and the promise of health equity. Sort of a large topic, something that maybe we're all not usually thinking about on a daily basis. But what I hope I leave you with is some food for thought for something that we should move towards. Okay, I have no disclosures for this talk. So what am I going to talk about this morning? I'm going to talk about what is digital transformation and why is it important? What has the COVID era really done for us with regards to digital transformation? And how did the issue of health equity come to the forefront? I'm going to talk about how health matters and discuss how health is really tied into the economy. And then we're going to talk about the quintuple aim, the imperative to achieve health equity, to achieve good health for everyone. And then what is our role as clinicians and as healthcare organizations for this aim? So I like the Simon Sinek book, which is to start with the why, what's the motivation, then the how, the process, and then what's the product. But recently, at the beginning of my presidential year, I read this book, Think Again by Adam Grant. And I think that a lot of this topic is about thinking again. How do you think differently about something that you have known and held true for many, many years? So let's start off with the fact that it's really imperative for us to know that we have made tremendous progress over the last 60 some years in terms of cardiovascular medicine. When it comes to developing, angioplasty so PCI to thrombolytics, thrombolytics to PCI to VAD therapy to statins. So we know that we have good science and good cardiovascular medicine. The other thing is important to remember is that we are an inherently tech avid field. We really adapt technology quite quickly as long as there's data there. So it's a tech friendly field, tech avid profession, and we tend to embrace technology. But I don't think that the problem is that we don't have good science or that we don't have good technology. It's that even though we've made progress, the system really hasn't made progress. And so what we see is that we're losing ground when it comes to the cost and outcomes. So the cost for cardiovascular medicine is so high that we have to take responsibility for the fact that this is a real issue. And particularly as cardiovascular disease is the #1 killer, and the fact that the health expenditures, so we have to take some ownership of this. And so we also know that heart disease is increasing at a troubling pace. And when it comes to outcomes, we're not doing as well. When you look at the global burden of hypertension and other risk factors like diabetes, obesity, we know that all of these are increasing. And all that does is set up the stage for a global epidemic of cardiovascular disease. And then when you look at it, we know how to provide care in the hospital, but we don't do as well when it comes to people at home. How do we care for them best at home? And then what we're left with is these types of things where there's non-adherence and all that. So although we do well inside the hospital, how do we provide care outside? And then we're left with this variation way beyond our control in quality of care and risk factor management, prevention, and health outcomes. And that is to some degree very frustrating for most of us when we see this level of variation, when we can provide such great care and we have great science. And then, of course, this idea of health equity, the fundamentals of US health policy, health equity, are we finally, how are we going to achieve health equity? Because we see these differences in outcomes. And so this is what sets the stage up for digital transformation. And the question is digital transformation the answer for health outcomes, patient satisfaction, all that? Maybe, probably. Is that the only answer? Could there be other things that we could do? Certainly. But why could it be? And that's what we're going to take a look at here. So let's go back about the same 60 some years where we started making all those advances in healthcare in terms of cardiovascular medicine. So this is 1956, and this is IBM shipping a 5 megabyte hard drive. And if you look at what's happened over the ensuing years, what we see is that we now have smartphones, 256 gigabytes for my smartphone. And the exponential growth in computing power, our ability to transport this and large pieces of data over the internet, has really transformed many industries, including transportation, including entertainment. But what about medicine? It really has not done that. So if you look at the same 1956, this is what a hospital waiting room looked like. And let's look at what's happened in now. Fundamentally doesn't look much different. And so whereas all of these other industries have transformed healthcare, in spite of the fact that we have made immense progress with CV medicine and CV science, and immense progress with technology and the type of technological advances we made, we really haven't made changes in the way that we deliver care, the way that the system has not evolved that way. And so when you look at it, some people would say, well, what about electronic health record? We certainly did that with electronic health record. And I would stop here and give you what I think is the definition of digital transformation. Successful digital transformation is something that would make our lives better. That would certainly make our patients' lives better and even our lives better. Now, it would take away some of our tasks. Now, if it adds a task, then ultimately it will make things better for us. So when you look at electronic health record, and I would ask all of you, do you think it made your life better? Probably the answer is no. We know data that was published early on in the Annals of Internal Medicine that looked at cardiology actually. And they said for every 2 hours that a cardiologist spends, every hour that a cardiologist spends with the patient, they spend 2 hours on the electronic health record. And remember what I told you was the definition of digital transformation is something that makes our lives easier. And I will tell you that we're about $36 billion into really a good record keeping system that was promising to even decrease, errors in medical. But if anything, we've seen more errors of documentation and things that we bring over. So really, this is not a model of successful digital transformation. So I thought this was funny. This is the market cartoonist. He does a lot on digital transformation. He says, are we all aligned that our top priority is digital transformation? Absolutely, 100%, of course. So what exactly do we mean by digital transformation? And most people can't define it. So I think that was why it was important for us to think about it, because if you did not know, then you embraced electronic health record as something that was digital transformation. And if anything, I believe that that's held us back. So what is digital transformation? I mentioned that to you, but it's really a disruptive improvement process, right? That introduces changes in information management, computing, connectivity technologies. Now, think of digital transformation as twofold. There's the internal facing that the organizations have to go through. So every healthcare organizations, including ACC, they have an internal facing, how they change their software, how they manage their data, how they interact with you as a customer. That's all internal digital transformation. And then there's the digital transformation that you and I may do when we are interacting with our patient. And we're going to talk about that a little bit. So, but there's a misconception that digital transformation is only disruption that's technological. But really, digital transformation is this wider framework that improves clinical processes. And it leverages vast data, improves clinical decision-making, and really improves the quality of care and increased satisfaction. So it's a little bit different than just technology. So I don't want you to think of it just as technology. So this is data from Cisco. Now I know this is not healthcare, but this showed Cisco Digital looked at what is digital transformation achieved in a bunch of different industries. Well, there was improved customer satisfaction. There was improved employee engagement, increased revenue. Now, I know this was not medicine, but this is real life data in the industry where digital transformation has taken place. So what can we expect if we were to apply digital transformation in healthcare? Well, system efficiency could be improved, patient engagement and satisfaction, clinician efficiency and satisfaction, and ultimately health and health outcomes. Now, who can argue against any of those as outcomes? So, for a long time, the Silicon Valley has been telling us that digital transformation is here and that the digital revolution is speeding up. And in fact, there's been an adrenaline rush in the United States in terms of funding. If you go back as far as 2010 and then look at where that is, and I have some later slides that show you what the most current data is, but the amount of money in digital health startups has been in the billions of dollars. Why? Because they believe that we're in the midst of digital transformation. And so the first half of 2020, believe it or not, shattered all VC funding records with $6.3 billion in new investments, which is 24% higher than a Q1 in 2019. And this is despite COVID-19 pandemic disrupting the economy. Why? Because we believe that this may be the answer to scale a lot of our problems. So this is why, if you look, there's a kaleidoscope of companies that have come about in the last several years. And these are all ones that are aimed at this digital transformation. So literally in any different sector. So you have companies that are looking at clinical administration, population health management, medical big data, remote patient monitoring, telehealth, all of this. Now, why have they not been successful? Well, part of it is that these are tech solutions in search of a problem. So instead of identifying the problem that they were dealing with, they were just coming up with tech solutions and then looking for a problem. They were also giving us a lot of data, but really sometimes what we need is not data, but what we need is actionable information. They also lacked clinical insights, and integration is sometimes absent in a lot of the work that they output. And then, of course, ultimately, even if they come up with something, are there payment models and is it cost effective so that we actually embrace this? So, this is from the World Health Organization, but they said digital health investments should address a health need. They should be appropriate to the local context, obviously, because we want to reach people where they are with digital technology. They should not duplicate existing digital tools or systems. And I'll guarantee you that if you looked at that list, there's a lot of duplication. And then account for long-term cost. Obviously, we would love to see some of this ultimately decrease cost. So, and there are a lot of really smart people that have looked at this. I mean, if you look, there's a lot of journal articles that have looked at, digital technology. So people like Topol and all of them have really looked at this. But unfortunately, the reason they've not gotten into current clinical practice guidelines is the evidence has been mixed. There's been variable clinical trial results. And so unfortunately, some of this really hasn't provided the data that we need for us to sort of embrace this. And so I guess if the digital health, if digital health is the future is not here yet. And that's sort of where we have come from. But, in 2017, we sort of started seeing these trends, and the ACC said, no, we really need to be part of this digital transformation. And so they actually in 2017 published a roadmap for innovation after they hired John Rumsfeld as a chief innovation officer. And this really said, what is the roadmap for innovation? ACC health policy statement that looked at healthcare transformation in the era of digital health, big data, and precision health, all of the components of digital transformation. And we said there are three major components of the internal facing digital transformation. One is virtual care. So how do you augment or replace what we do now, right? To improve access, efficiency, communication, and the patient experience. Is this just telehealth? I'll tell you, I don't think this is just telehealth. And we'll talk about this more. Remote monitoring, well, patient remote monitoring, we're already doing some of this, right? So utilizing data that we didn't have before. And why this is important is because maybe this can inform prevention, care management, health promotion. So these are these mobile, devices, biosensors, things that can give us data. And maybe if we know what a patient looks like when they're well, we can tell when they're sick early on. And ultimately that can maybe decrease cost. So a lot more focus on prevention with this sort of technology. And then lastly, AI-driven care. When we get deluged with data, we feel overwhelmed. If you talk about clinician burnout, well, burnout is when you get too much paperwork to do. And that's been one of the big things that has been the reason for burnout. So AI-driven care would say that these are analytics that improve maybe in image interpretation, risk prediction, diagnostic and therapeutic care recommendations. Wouldn't it be nice if when your patient wants to send you wads and wads of paper from their iPhone or from their, AliveCore, that could be put through an AI algorithm. And so you know exactly what you have to look at. And it could help us with being less worried about medical legal issues because we know we can drill down. So AI-driven care. So when we think of digital transformation from the ACC perspective, we're thinking about virtual care, remote monitoring, AI-driven care, all three components and how they marry together. And I will tell you that to truly do virtual care, we need more than telehealth because what we need is some additional data, like blood pressure and ECG, even heart sounds would be great. So the more data we have, the more robust our virtual care will be. And so what did the COVID era bring to us? Well, first thing is, digital transformation is years away. That's what people thought. And we don't see it coming through. So COVID-19 was that sort of, the wrecking ball that kind of came and changed our thinking. And so if you think about who led the digital transformation, well, in companies, they say, well, the CEO, the CTO, no, COVID-19, I think, was the sort of driver there. So here's the story of telehealth. I think that when you think about telehealth before the pandemic, we had about 5% uptake of telehealth. And then at the peak of the pandemic, we went up to 90%. And I will tell you now, cardiology is pretty much settled into about 30 to 40%. So, this propelled by the new normal associated with COVID-19, we saw a surge in technology innovation and continuity in care delivery. So that's why I think the genie's out of the bottle. I don't think we can go back on telehealth. That 40% could certainly trickle upwards if we can continue to refine what we need to provide that actual virtual care. I will tell you that the telehealth worldwide market has been projected to be over $131 billion because we think this is here to stay. So Jack published a paper last year that telehealth is having a moment. Will it last? And so they looked at virtual care and said, if you have payment model, you have regulation that will propel virtual care. And we all recognized in that process that we need ECG, blood pressure, potentially oxygen saturation, heart rate, all of the data that's missing right now on just a pure telehealth platform. And so wouldn't it be nice if we had a kit that everybody had that could give us some of that data that we need to be able to really provide virtual care? Now, I talked about the fact, going back just a second, saying payment model and regulation. Well, they did that emergency payment model, so we were able to get paid. What about regulation? Well, COVID-19 did change that. In fact, there were 80 new services that were telehealth greatly expanded through Centers of Medicare and Medicare, temporarily approved more than 80 new services, lifting restrictions and all of that. So that's something we're going to have to keep an eye on. So I believe going to virtual care, we need a platform. Could be a telephone, ideally would be a video. We need to be able to also message people. We want to be able to have remote patient monitoring data incorporated. And then that can help us create management pathways and hopefully, ultimately, therapeutic pathways that would provide that continuum of virtual care. Now, what else did COVID do? Well, COVID amplified our healthcare inequities in the US. We found out during COVID that African Americans had more COVID-19 exposure and infections. And I think it really brought to light the health inequities, which really have existed in society for decades, but we really shone a light on that. And I think that was something that became an imperative for us over this last year. And then I think the other thing it did was it underscored many of the existing issues, right? So how much health really matters. I'm sure we all have thought about how much health matters. We also realize that health and economy are really linked. And the imperative of the health equity is really important because it's how we're going to achieve good health for everybody. So what's the data to support all of this? Well, it's estimated that the impact of the pandemic on the US economy is 4 to 7% reduction in our GDP. That's huge. And the McKinsey Global Institute research reported that if we prioritize health, we can present an economic opportunity of $12 trillion by 2040. Isn't that amazing? And it's been estimated by the Institute of Healthcare Improvement that health inequities can cost the United States $83 billion, and it's anticipated to grow $300 billion by 2015. Huge numbers. Now, this isn't news for us because this is some data from 2018 and beyond. And we knew that some of this was there. There was a case for health equity. We knew health disparities were costly and that there would be a positive economic impact if health equity was better implemented. So this isn't news to us, but I think we finally are paying attention because of what happened during COVID-19 that really shone a light on us. So I think we need to rethink our focus. In the past, the discussions about economic growth have focused on controlling healthcare costs. How many times have we heard we need to cut costs, we need to cut costs? But they never talked about how can we promote health? And maybe if we promote health, we actually control healthcare costs better and we actually stimulate economic growth. We know poor health results in premature deaths and lost productivity. It costs at least the US about $3.2 trillion annually. We spend 16% of our GDP on healthcare costs. So given this, maybe it's time for us to rethink health as an investment rather than, just something than just a cost. And I think that's a different mindset. So this is where my next leadership page really focuses on this quintuple aim. And let me tell you about that. So the Institute of Healthcare, came out with this triple aim in 2007, right? And it's about improved patient experience, better outcomes, lower costs. And everybody, all healthcare systems sort of rallied to say, we've got to go for the triple aim. I mean, how many of you heard this? Then in 2014, somebody said, hey, we're not really achieving the triple aim. And why is that? Well, because nobody thought about the clinician when they put out the triple aim. Well, in order to do healthcare, we need clinicians. And so all of a sudden, the issue of burnout came out and healthcare clinician well-being became central. So the quadruple aim was to take all three of the triple aim and add the fourth aim, which was the clinician well-being. Well, I'm here to propose to you that in 2021, maybe it's time for a quintuple aim, which is we need the triple aim, we need the clinician well-being, but what we need is health equity. Why? Because that's how we're going to get to better health and improved economy. So you can read more about this in my next leadership page that's coming out. But I was fortunate enough last year after Floyd's death, George Floyd's death, they talked about social justice. And we at the college talked about social justice for us is about achieving health equity. So we launched a health equity task force, and I was lucky enough to chair that. And so the question was, how do we do this? How do we move forward? Well, interestingly, if you look at the ACC strategic plan and look at the box in blue, and it says advance quality, equity, and value of CV care. Well, I can tell you that's been on the previous strategic plan also, but we never really actualized it. And this was an opportunity to say, how can we improve access of care for underserved patients and population? And how can we reduce the system and structural barriers that cause health disparities? So came up with this pictorial, which was to say, can we leverage the infrastructure from the college, advocacy, education, and science? And can we then create the road to health equity? And we said achieving cardiovascular health equity, not just health equity, but really honing in on cardiovascular health equity, ensuring quality health care for all, and ultimately optimizing cardiovascular care and heart health. That's our goal. How do we do this? Well, we created a whole strategic plan. And so we have the ACC Health Equity Strategy, 3 goals: create a culture of health equity in cardiovascular medicine, prioritize health equity in all of our ACC activities, and then eliminate the disparities by ensuring equitable cardiovascular care for all. Now, it sounds like all of a no-brainer, but we not only created those goals, but we also created strategies, and now we have metrics to go with that so that we can actually execute. We're in the midst of a 5-year ACC strategic plan, and we do strategic priorities every year. And at the last board meeting, we actually affirmed that health equity be integrated in and really we can interdigitate all of this into our into our strategic plan. So you're going to hear a lot more from the college about health equity and how do we scale this. And so one of the things we tackled is, we've heard all these terms: health inequity, health disparity, health equity, social determinants of health. What do they mean? And we actually defined all of those terms from a cardiology lens. So let's take one, for example: health inequities, systemic, avoidable, and often unjust societal factors, structural practices and racism that cause barriers to opportunity and result in avoidable adverse health status and outcomes. Now, health disparities, adverse cardiovascular outcomes that's attributable to systemic, avoidable, and unjust societal factors, structural practices, and health equities cause cardiac health disparities. So interesting. I mean, health inequities can cause health disparities. But I think that it was important for us to define it so that we were all on the same page. And some of this, I have to tell you, this exercise was quite painful to go through and figure out exactly what we were talking about. So I want to talk a little bit about social determinants of health. These are the conditions in the environment where people are born, live, learn, work, and play. And so, and they can be, really grouped into 5 domains, right? Education, access and quality, healthcare access and quality, where we live, the neighborhood and the built environment, social and community context, what's our support systems, and then economics, right? Now, interestingly, if you look at this diagram, which I really like, and you look at a total person and what percentage everything is, interestingly, healthcare is only 20% of the social determinant of health. And health behaviors, physical environment, socioeconomic factors, they make up 80% of the social determinants of health, right? And so 20% of a person's health and well-being is related to access of care and quality of services. But the physical environment, social determinants, and behavioral factors, 80%. Now let's take a look on this other graph, the US health and social care spend. We spend, 16% of our GDP on the healthcare spend. That's 20%, remember. And we spend 9% on the social care spend, which is 80% of the determinant of health. So that's an important thing we need to look at. So I did a JAC leadership page on health equity in May of 2020. And I said, paving the road to health equity, why does it matter? And this, I think I talk about a little bit more of all of these things in there. But I think that at the goal, we need to have health equity. And so we need data to understand the individuals and the populations we serve. How great would it be if every health system collected the social determinants of health when patients checked in? We must identify these social determinants of health and then figure out how we're going to do this. And then really target prevention through multiple channels, right? And really, because we need to look at the intersections of various diseases. Because cardiovascular disease is number one, we need to work with our oncology colleagues. Why? Because as they're doing a better job, guess what? Those patients are living their cancer and dying of heart disease. But maybe we need to target some of those patients. What about cardio-obstetrics? We know that when a woman has a pregnancy-related complications, she's at much higher risk for long-term cardiovascular disease. Maybe we need to identify those patients early. So we need to look at these intersection of various diseases. We need to be diligent about removing implicit bias and structural barriers. And we need to harness technology. And this is where I think digital transformation, and I'm sure you were wondering, well, why is she talking about digital transformation and health equity? Because I believe that we can only scale health equity by using technology. And by really doing digital transformation, we may go from that episodic care to sort of that continuous well care that we need to do. So look at technology and innovation on one side and health equity. And those are the two pieces that need to come together. Now, we learned when we did telehealth over the COVID pandemic that people loved it. They loved being at home on their computer, on their tablet, or on their phone. Why? They didn't have to be trying to find a parking spot. They didn't have to wait for a bus to come and see you. They didn't have to find a parking. And then we know that patients really like getting their home care. They feel safe. And we know technology is getting cheaper, right? The number of smartphone users in the world have increased tremendously. And it's become ubiquitous and cheaper. And really, it is a digital world, right? And so we know that. We know that there are almost 5.3 billion unique mobile phone users. That's almost 67% of the world population. We know that there are almost 5 billion internet users and almost 4.5 billion active social media users. So we have the ability to really reach huge numbers of people if we decide to be digital. And so digital technology has been shown to do, in population health approaches and as a strategy for equity. So digital technologies may be one tool for addressing health disparity and improving population health. Why? Because it increases individuals' access to health information, particularly in low-income US residents. Why? Because we can give them access to smartphones. Organizations can use digital technologies for collection. What I said to you, they can collect data that way. They can provide information, they can push out education, and then for sharing information. And so I believe that when you combine sound policy strategies, emerging scalable technologies will likely become powerful allies for us to improve healthcare and reduce healthcare disparities. So, and this has been shown, there's lots of data. If a rapid review of some evidence published from January 2008 to 2020, and a majority of these studies, focused on race and ethnicity and low economic shift, and it assessed what the impact was of digital health interventions particularly in cardiovascular disease. And what it showed is that it improved health or healthcare delivery. And outcomes in 63% of the included studies, which is a good start. And I think that they use telemedicine about 42% of the time. Mobile health, decision support tools were the most common digital health interventions. And, you know, some of these studies were in 2008, and you can well imagine that we've made a lot of progress in those years. And what would this study look like going forward? And I guarantee you it would be higher than 63%. So again, why does digital health technology work? Well, people like to be where they are. So let's look at the barbershop study. It was really a fantastic study that showed that if you bring care to where people are, that it works. So this was a Black barbershop patrons with uncontrolled hypertension were randomized to interventional therapy and standard therapy. And interventional therapy consisted of barbers who promoted monthly follow-ups with pharmacists, right? And look at what they did. They had better control of their blood pressure. So amongst Black barbershop patrons with uncontrolled hypertension, interventional therapy was effective at reducing their blood pressure at 6 months compared to standard therapy. What was standard therapy? Going to their doctors. And they found that here was a place where they trusted. And so I think this idea of being able to go where they are through digital technology could be very helpful for us. This was a study published about STEMI care. You've heard that there's always been that STEMI care maybe is not quite as equal for women. And so one of the articles that really talked about that is, could we use artificial intelligence to use predictive modeling of features of STEMI to provide a standardized approach to care? And maybe that would eliminate implicit bias. And, you know, you can do implicit bias training, but maybe we need some of this to really remove that implicit bias and improve care of women and other groups that maybe we have implicit bias on. And so very interesting, I think, a really interesting study and to eliminate sex disparities. This is Gero technology. It is the promise of improving care in older patients using digital health technology, because some of them have access issues. Some of them can't go. So again, lots of things. So Gero technology is another area where I think we can make some strides. So let's look forward. Going from 2020 to 2021, we made this leap. And where we are now, 40% telehealth compared to last year. But what about going further forward? Where are we? Well, I want you to look at this slide and says spending on technology post-COVID. And this is all industry specific. And if you look at this, you know, this is, look at IT industry, media, manufacturing, and healthcare. And what we saw is that healthcare industry had the most amount of spend. So there was a huge acceleration in technology spending in healthcare. Why? Because I believe that everybody is starting to recognize how important technology is, how important digital transformation is for healthcare. This is a slide from Cheryl Pegas, who is, she is the chief medical officer for Walmart. She gave a talk recently at the Quality Summit, and she mentioned that with COVID, there were 4 issues that came out, 4 main drivers that influence healthcare innovation. One is that government-funded programs and employers are the largest purchasers of healthcare, but their needs continue to be unmet. So, you know, 90% of this $3.8 trillion plus healthcare market flows through employers, CMS, and insurers. About 55% of healthcare market is funded by government, and the government really doesn't feel like they're getting their value out. Value-based care has, so number 2 bucket is this value-based care has started, but the needs to accelerate. So 5-time increase in the number of consumers in a value-based arrangement between 2015 and 2020. Yet 80% of healthcare spend, it remains traditional or effectively fee for service. So yet people are going into these value-based arrangements, but we're not transitioning there as yet. And then consumerism is on the rise, and the demand for digital and telehealth solutions to manage healthcare has increased. 4 times increase in patient telehealth use in 2020 versus 2019. And then 62% of consumers would choose a virtual solution for basic health and wellness. And they actually go to pharmacy looking for this and places for this. So that, and then the last one is those with barriers to health have worse outcomes. We know that. And the zip code we recognize is more influential than traditional healthcare and genetic code. So 70% of health outcomes are based on social determinants of health and personal behaviors. We talked about that. I think it was more 80% really, but maybe that's transitioned to closer to 70. And this is her slide. 86% more likely to have diabetes as American, and so again, I think that we are seeing a shift, and I think these are going to propel digital transformation. So Clay Christensen is an author that said disruptive innovation is what we need. Innovation is a process, right? So when you have new things come in, you need it to be, when you introduce new products, less expensive, more accessible would be ideal. And usually things that are around, what they do is they improve current products and services because they say, well, you don't need all of that. But what they tend to do is ignore the needs. And I think the reason that some of these newer things are successful is because they target all of these things that have been overlooked. So they do think about cost. And so I think that the technologies that are going to be most successful will sort of think about how accessibility and all of that. So value-based healthcare, right, is a concept that was coined by Michael Porter that said transforming healthcare systems with the primary goal to maximize value to patients. That's what value-based care is. So I don't think digital transformation is going to be a panacea for all of the vulnerabilities about the healthcare system. But I do think that it is the foundation of a future modernized healthcare system. And I do think that it's a pivotal initial step to facilitate that transition to value-based care. I don't know how else we're going to scale value-based healthcare. And so when you look at this, disruptive innovation, success of value-based care is leading a shift in care models to focus on outcomes. So when you look at underserved population, there's 121% Medicaid managed care plan enrollment that went from 26 million to 56 million between 2010 and 2018. We have an aging population, 219% growth in Medicare Advantage enrollment between 2000 and 2019. And then legislation, 35 states acted to expand access to government insurance, right? 35 states moved to Medicaid expansions in 2014. So there is disruptive innovation occurring, and I think we need to really be paying attention. So I do think this focus on health equity is important. Health improvements, it translates to tremendous economic growth. I mean, it's been estimated that 2 million more people could join the labor force and about 5 million greater workplace productivity for 25 million adults. So people who previously had a disability or needed to be full-time caregivers, older adults would now be able to delay retirement, and employees with chronic conditions that interfered with employment could focus more on their work. So I think that these statistics are to be taken seriously. I think that it could add to an increase of $3 trillion or 10% increase in the GDP by 2040. So why does health equity matter? I think that quintuple aim with the pursuit of health equity is an investment that has the potential for being a societal and an economic game changer. I think that there are social benefits. I think there are economic benefits, and I think that we have to take those seriously. I want to touch a little bit on the digital divide because I don't think we can talk about digital transformation without talking about digital divide. What is it? Well, digital divide was really evident also during the pandemic. It showed decreased access to care for some of our society's most vulnerable due to the lack of ubiquitous technology, right? So digital literacy and internet connectivity. So we do need to think, as we think about digital transformation, about that digital divide. How do we make sure that there is digital literacy? How do we make sure that there is, wide broadband availability? So, and we have to remember that digital health technologies interact with social, cultural, and economic realities, and with the social determinants of health. And that really contributes to health equity. So we really need to think about this. So investments to build, to bridge the divide in access, use, and the use of these interventions for those that are lower socioeconomic status. Maybe you take certain zip codes and maybe we need to give some of that technology to some of them, or really cut the cost for some of them. Design and research agendas to incorporate a diverse set of users, because when we do research, we need to take into account some of those diverse set of users, people that are historically underrepresented in large studies. And then ultimately, we got to support multi-directional communication amongst patients, provider teams, and digital devices. And really what we're going to need is data governance, right? To harmonize and protect the real-time exchange of data. So I don't think innovation should reinforce the social gradient of health, and where people that are less disadvantaged, less advantaged socioeconomic position have less access, poor quality, or worse health outcomes. We need to make sure we think about equity. And this is where I do think health systems have to be involved. I think that moving the dial on health equity, including digital and technology health equity, requires looking beyond individual factors really to health systems. And I do think that those of us sitting at the C-suite, we need to be making sure that we get that message to our health systems about the things that they can do to help with this. And so when we think about quality resource optimization, I think our C-suite also needs to add the third bucket, which is health equity, and how recognizing that an equitable health system affords every individual a fair opportunity to get to the highest level of health. And remember, if they can get health, it impacts the economy, I think, in a very positive way. So I think the use of technology really extends into and is shaped by an individual's social, cultural, and economic position in the world. And I think that if we really need to think about that, even when we're developing institutional strategies or funding and payment models for providers, particularly working for vulnerable populations. Otherwise, I think health equity, the quality of care will suffer and health equity will be impacted. Now, part of the reason I gave this talk is that I think that we as cardiovascular professionals have to lead the way for innovation and digital health development. And we have to adopt it and couple this with our desire, our strong desire to help patients be as healthy as they can be. And really that is the definition of health equity. So I think we need to shift to the quintuple aim. And I think we need to recognize that this is that investment in our future. And, you know, Franz Grodel was one of the founders of ACC, and he said, we will meet the future not merely by dreams, but by concerned action and inextinguishable enthusiasm. And I think we have a lot of enthusiasm, but we need to have a lot of concerned action. So I'm going to stop here and I'm going to make a shameless plug for my Coffee with the ACC president, which will be next Saturday, November 10th. It will be 7 a.m. on the West Coast. I am going to be talking to the top gentleman up here is Vincent Covello. He is a world expert on stress communication. In fact, he was hired by Japan during the tsunami to communicate that. Actually hired by the city of New York and the state of New York for communication during 9/11. So he will tell us how do we communicate effectively during stressful times, and certainly COVID has been one of those, and maybe even touch on some issues of vaccine hesitancy. Our second guest is Dr. Heyer, who's the Vice President of Medical Affairs for Moderna, and he is really very knowledgeable. Both of these gentlemen were the ones that did the Q&A for the World Health Organization when it came to COVID. I think it'll be a great topic about communication, change, and adaptation, and really about all of that. So I'm going to stop here. Thank you very much for your attention. I wanted to make sure I left some time so we could have some questions, but thank you very much for your attention.
Wow, that was so amazing. Thank you, Dr. Ichaporia. We really appreciated your perspective there. I think that it's mind-boggling how the tech and innovation aim of this kind of definitely dovetails into the equity goals that the college has. I'll start with the first question, and if anybody has questions, put it in the chat or the Q&A. We have a few minutes here. But one of the struggles that I've had here in rural Washington, and I know a lot of my colleagues around the state have had, is we completely see everything that you're saying and really are trying to make those differences at the patient level. How do we convince our organizations? How do we convince the C-suite that this is important? What are your thoughts on our approach? Cardiologists are kind of at the lead in most of these organizations. How do we approach our organizations and try to convince them that these issues are important for us to achieve the quintuple aim?
Yeah, I mean, I think that data is what would drive it. So I think provide some of the data, show them what the economic, plus point is for health equity, and what does digital transformation help us to do and honestly, systems, and we are all going to be held to this. Outcomes are what the government is looking at as the next metric. They want better outcomes. And if you notice, that's what, our systems, as long as if there's financial ties to it, all of a sudden they kind of jump up to look at this. And I think we need to have those conversations. If we're in the C-suite, start talking about these things, talk about how this is important and what can we do to be in the forefront. The other thing is that I think it's important for us to give feedback to tech partners. So I think if there's anybody that's interested in, like, we have an innovation section, and the college partners with a lot of tech companies, and so we give feedback as to what we need for all of this to be adapted. So I think having conversations amongst ourselves, having conversations with our administrators and the C-suites, and giving presentations, not necessarily maybe this large, but even miniature versions of this, and having those conversations and saying how important this is will sort of help hopefully move that needle. I know that I try to do that with my administrators and say, hey, what are we doing? And they actually hired a digital transformation officer recently.
Wow. No, that's fantastic. Thank you. That's really helpful, actually. And I think the ACC, if anything, has a lot of data and resources kind of to maybe leverage going forward. Arun Sridhar in Seattle has a question. A lot of digital innovations have been driven by the tech companies, and we're seeing that we're getting a lot of data on patient care, and that was accelerated by the COVID pandemic. His specific question is, going forward, what are the active efforts from the college to collaborate with and harness the tech companies to pave the future of preventive cardiac health?
Yeah, I know it's a great question. So thank you for that. And that's what I was saying, Arun, that the college has been early on invested in, I think at this point, our portfolio is about like 15 or 16 companies that we've been working with to actually co-develop some of the products that we can use and really sort of getting the message out. I spoke at the Consumer Electronics Show a couple of years ago. Now we actually have a pathway at the Consumer Electronics Show that we co-develop, because what we found is that the engineers are wanting to interact with all of us. And if you really look at the landscape of a lot of the innovation companies, a lot of cardiologists are starting to get very prominent positions in some of those companies. Why? Because this is a really important field. So the college is doing things. If you are interested in getting involved, I think getting involved in the innovation section is really important. And then at some point get on the Innovation Council, which is the leadership council, to do that. But we want to hear the voices, because I think a lot of our younger cardiologists coming out have a lot of great ideas and a lot of expertise in all of this. And I think that's going to help propel us forward further.
Thank you. Yeah. Another terrific question coming up here from Nagin Shahande, and I think she's down in your neck of the woods at UCLA. I'm not 100% sure of that, but she asked a really good question, which is that she said, I feel that medicine is unique in some regards because the personal connection between the provider and the patient is often imperative to a patient's experience and to achieving good outcomes. Are you concerned that the increase in digital health might make it more difficult for patients and physicians to connect? What are some ways you think we can maintain the human touch while we start to incorporate these important changes?
Well, I think it's a great question. I think, first of all, I'm not suggesting that every visit be virtual alone. So number one, that. So you definitely need to have some face-to-face, just like we were talking about meetings, we need to have that, in networking and all that. The other thing is that I think that's why I was saying that it's not just a 2-minute telehealth visit. If you're going to do true virtual care, one of the things that's really nice about one of the things that I found really nice about the telehealth visits is that I got to see where they live. And that was really interesting. I have some patients that live, in various different places. And some of them happened to be there when I called, and they said, oh, I'm here. Let me show you around. And then they would show me. And now I had a better feel for where they're physically. So maybe when we're just seeing them in a clinic visit, we don't get that other pieces of the social determinant of health. What does their environment look like? And maybe if we can start to think how important those pieces are, maybe that's just only going to make our human touch even better, because we recognize the issues that are there. We may be able to say hello to other family members and see what their support is, look at their physical environment, all of those things. So, do I think the digital is going to be 100% perfect? No. Do I think we need to continue to do some face-to-face visits? Yes. But imagine that if some elderly patient that's the son or the daughter has to take the day off and pack them up and bring them in, and it's really difficult. Instead of doing that, very frequently, if you could decrease the number of times they do that, and be able to do it digitally, that may be helpful so we can still get much better care and more frequent care for some of the really chronically sick patients.
Yeah, I think those are great points. And a question to kind of dovetail on that, Mayar Puriyahi is asking, how do we advocate for our patients that are marginalized in the digital world? So, some of these patients that you just referred to, and maybe their family members, how do we ensure that we advocate for them as cardiologists?
Well, that's why I think we have to have a conversation about digital divide and recognize that we may be able to, we are going to marginalize some of those patients if we go too fast without thinking about those people. This is why I encourage systems to sort of start thinking about collecting some of this data on social determinants of health. We need to all start thinking about that for our patients and say, where are they? What zip code do they live in? Maybe we need to categorize some of those patients that may need a little bit more help. But ask those questions so we can start to identify those patients. I think a lot of the reasons we don't ask is we don't really have solutions for all of that, and it becomes sort of overwhelming. I mean, it's not that we don't want to, but we need to start doing that so that at least we can come up with an answer.
And Richard Cheng asks, I think, a timely question here, which is, you've got this rapid uptake of digital information and technology. How do we leverage this data for research to address gaps and disparities given the underlying concerns for privacies? That's transformative for clinical care, but how do we address the privacy concerns?
Right, and this is why in my slide I put that we have to have some some changes in regulatory event and as to how we do data management in this era, because I agree with you, these digital platforms will allow us to transform research. And if we can gather some of this data and look at it, but how do we do that? We need to have better protections and ways to make sure that we have privacy. I don't know the answer to that, but I think that it's absolutely a question we need to ask and make sure we keep getting an answer for.
Well, I can't thank you enough for really, this is a hard topic. Really frame it in a way that was it resonated quite a bit with me. I'm sure it resonated with a lot of people, and really appreciate you coming to this meeting and giving our keynote today.
Yeah, thank you so much for inviting me. It's been a pleasure, and I wish you luck for the rest of your meeting.
Thanks. And maybe before you go, I can make a quick announcement. I think my screen is frozen, but hopefully you guys can still hear me. I'd like to basically just make the announcement that Richard Cheng, who is on the call here, is going to be our next Washington chapter ACC governor and president. He'll start in 2023. So this is kind of the first that anybody is hearing about it in our chapter, and I thought it would be appropriate to announce it while you were here giving our keynote address. So Richard, congratulations on that. And with that, I'll actually turn it over to you for the rest of the meeting here.
Yeah, Gotham, let me just say congratulations to Richard. You're going to enjoy it. It's a fantastic opportunity. So welcome aboard to the ACC. I mean, all of us are part of the ACC family, but now you'll be a closer family member.
Great. Thank you so much, Dr. Shapura, for the amazing session and keynote and discussion there. And I'm very excited for this opportunity. Great. So now we're going to move on to the rest of the agenda. Before we move on, I did want to mention that yesterday, Dr. Tim Ball had some technical difficulties. So at the end of the meeting today, or at around 11:30, he's going to give us talk on target lesion versus multivessel PCI. So our next session is going to be for heart failure. I wanted to introduce Dr. Deirdre Mooney, who's a heart failure cardiologist at Providence Sacred Heart in Spokane, a very close friend of mine, and our amazing advanced heart failure fellow, Dr. Mayar Puriyahi, who is currently at the University of Washington, for this next panel of speakers. Great. Dr. Mooney and Dr. Puriyahi, do you want to introduce the next speakers?
All right, good morning. Can you hear me?
Yes, we can.
Perfect. All right, thank you, everyone. Dr. Mayar Puriyahi and I have the honor to bring you exciting talks from three giants in the field of heart failure.
So with that being said, we are going to have Dr. Richard Wright joining us. He did his, I want to give a little bit of a tidbit about all of our excellent speakers. He did his residency and cardiology fellowship at Brigham Women's Hospital. He's currently the co-director of California Medicare Contractor Advisory Committee. He's held multiple advisory and advocacy roles at ACC. And on a fun fact, he was a cardiologist for the great apes at Los Angeles Zoo. With that, I will hand this over.
Okay, thank you. We have three exciting giants in the field who have contributed in so many different ways through national guidelines, patient symposiums. I'm excited to hear what everyone has to share. Please save your questions for the end or put them in the chat box if appropriate to answer.
Okay, well, thanks very much. Deirdre, can you hear me now?
Sure can.
Okay, great. So what I've been charged with doing is trying to tell us what we can do in 2022 about prioritizing medicines. This didn't used to be an issue because we didn't have that many arrows in our quiver, but rather remarkably, the field has burgeoned of medications that are useful for the heart failure state. So let's see what we can accomplish about that today. These are my disclosures. I am a speaker and do consulting for many of the companies that make products that we're going to talk about today. So first of all, I'm not going to spend much time on defining heart failure. You're going to hear about that in a minute. But just remember that this is a syndrome, and hence the medicines that we're going to talk about may be useful for parts of heart failure that we previously didn't consider to be medically treatable, perhaps. And whether or not you use biomarkers, whether you use cardiac objective dysfunction, we're going to hear a little bit about that in the next half hour. But I want to move on just to the medications and give you a bit of a background in terms of the medical history of this. So the first of the effective therapies in terms of reducing mortality was enalapril. And enalapril only was used in heart failure because captopril had preceded it. And the manufacturers of enalapril didn't think they'd have a market in hypertension. So they turned to some investigators who had looked at animal models and thought that ACE inhibitor therapy might be useful for treatment of reduced ejection fraction heart failure. And of course, here is the SOLVED study in which individuals with reduced EFs were randomly assigned to enalapril or not. And remember, this was in many decades ago, and hence modern therapies weren't utilized. But clearly here you see that enalapril was better than placebo. Although I will point out that the delta here as the years go on does not get very great. So ACE inhibitors were terrific in their day. And indeed, if you look at subsequent ACE inhibitor trials, the overall mortality reduction was about 20%, more so in sicker people, like in the consensus on the far left here. For prevention of heart failure, not so much. There was a 10% reduction in the SOLVED prevention trial. And post-MI trials with reduced EF, there was about a comparable mortality benefit. So we'll say perhaps 20% reduction with ACE inhibitor therapy. One thing that remains unknown in this field is are higher doses in fact better? It's very difficult to design a clinical trial that documents this. But if you look at low doses in red, medium doses in green, or higher doses, and this is true of both ACE inhibitors and angiotensin receptor blockers, it appears that at least individuals who can tolerate higher doses do better. So it's possible we could eke out a little more benefit using these renin-angiotensin modulators, depending on the doses that we administer. However, what changed was the realization that you could do better than ACE inhibitors, and here is the paradigm trial in which patients were randomly assigned to either enalapril or what's listed here as ARNI, which is sacubitril valsartan or Entresto. And you can see that there was indeed, in terms of overall events, this one being CV death and heart failure hospital stay, an improvement in patients randomly assigned to receive the ARNI rather than enalapril. And these curves diverged fairly early and continued to diverge throughout several years of follow-up. You can see then in yellow how statistically significant this was, with the number needed to treat of only 21. So in large part, the ARNI has replaced ACE inhibitors, at least for individuals with class 2 and class 3 reduced ejection fraction heart failure. And then if you look at reduced ejection fraction heart failure versus death, you can see there's a 20% additional reduction. So enalapril versus placebo gave you a 20% reduction, and here you got an additional 20% using the ARNI, just with the NNT of 32 to reduce a death over the ensuing couple of years. The remarkable thing about these is that it's very difficult to distinguish looking at typical subgroups, and these were all pre-specified subgroups, whether somebody was younger or older or male or female or had a higher or lower N-terminal proBNP, et cetera. The etiology, their reduced EF, it didn't make any difference. It seems like the reduced ejection fraction heart failure state would be improved if you gave the ARNI. So the good news there is that everybody would seemingly benefit. The bad news is it doesn't help you and I decide whether a particular drug is useful. If everybody benefits, then you could argue that everybody needs to get the drug. Now, when Greg Fonarow looked at these data and then tried to apply them across the United States, the remarkable thing was because we have relatively slow uptake of these new drugs because of clinical inertia, cost of the drugs, et cetera. It turns out somewhere between about 20 and 40,000 lives per year would be saved if all the eligible patients, and I'm excluding people with renal failure and with hyperkalemia, et cetera, but all the individuals with reduced EF heart failure, if they were switched from an ACE inhibitor to an ARNI, and you can see on the right, at a quality adjusted life year cost of only $35,000, you could save a life. And yet, even to this day, the uptake of these newer agents has been slower than perhaps we would recommend. Now, remarkably, the same drug turned out to be useful for people whose ejection fractions were not historically classified as being reduced. This is called the Paragon trial. And these particular individuals had ejection fractions of 45 or higher. And what you see both in men and women, there was a slight benefit at low EFs, but this was principally driven by women. And so women that have ejection fractions below, say, 60 to 65% benefited from this drug if they had the heart failure syndrome. And indeed, one of the themes you're going to see in the coming minutes is that if someone has the heart failure syndrome, many of the therapies that previously were felt to be useful only in individuals with greater degrees of reduction in ejection fraction now turns out that patients with mildly reduced EF, so remember the normal EF for a man is above 52, for a woman above 55. If individuals have EFs below that, they may well benefit from some of these drugs that historically we've really kept only for individuals with EFs of 40 or below. We need to reassess that, as I'll show you. Then, of course, came beta blockers. Now, back in the 1970s, when I was in medical school, beta blockers were avoided in heart failure. And in fact, even if you look at the bottom here, I went last month onto Wikipedia and downloaded this quote: the beta blockers should not be used in most of those with heart failure. I mean, how wrong can that be? How did we go wrong? Well, the reason we went wrong was because in red is a normal heart. And as you know, there's a positive force frequency relationship. If you take a papillary muscle from a heart and you drive that papillary muscle at a stimulation frequency of 30 per minute or 60 or 90 or 120, the normal heart beats more strongly the faster it beats, up to about 150 in the human heart. This is, of course, different in other animals. But in green is explanted patients whose hearts were taken out because they had a heart transplant due to non-ischemic dilated cardiomyopathy. And what you see with them is they have the reverse force frequency, in which the slower the heart beats, the better it beats. And this is due to fundamental differences in everything from calcium handling in the sarcoplasmic reticulum to genetic transformations that occur in terms of gene expression in the failing heart. And hence what you observe in a normal individual may not hold in an individual with heart failure. And that's why when you look at the first of the large beta blocker trials, this is the metoprolol succinate trial, the MERIT trial. It turns out that the ejection fraction remains the same. And you can see in this particular trial, it was around 23 to 25% at baseline on standard therapy, which in those days was diuretics and maybe digoxin. But on the right-hand side of the curve is metoprolol. And metoprolol increased the ejection fraction over a period of time. It took about 12 weeks for this to occur, by 9 ejection fraction points. And that remains the highest increase of any pharmacologic intervention, which is why beta blockers are considered very important as cornerstone therapies. And this was true, again, as I showed you with the ARNI, across all spectra. It didn't matter why you had reduced EF heart failure or how old you were, how young, metoprolol benefited you. Everything here is to the left of the line of unity. Hence, beta blockers are perhaps the most important of the classes of medicines. And that's why they lead, as you can see in the red circle here, to a 34 to 35% reduction, at least for the 3 beta blockers that are approved in the United States for reduced EF heart failure. And those are bisoprolol, metoprolol succinate, and carvedilol. Bucindolol, the top one, had a numerically small but not statistically reduced death rate. And this was partly due to differences in genetics of the people who were enrolled in that study. Now, is this just driven by heart failure? Well, we have some evidence that in fact the beta blockers do in fact achieve this by heart rate reduction. And that came from a different trial in which drugs were added. In this case, the drug was isradipine, which is a direct SA nodal heart rate reducing agent. And you can see here 36% reduction in death over about 2-year follow-up in these individuals, thousands of individuals randomized already on beta blockers to either getting isradipine or not. And the most important observation from that study was this, and this is in green are people who achieved a heart rate by 12 lead EKG. This is not heart rate when the person walks in and has the MA take the heart rate or when you take a heart rate. This is on EKG. But if somebody achieved an EKG of 75 versus 70 versus 65 versus 60 or below, you can see the benefit in the composite endpoint was dramatically different if somebody had a heart rate of say 62 versus 72. And I would posit that most people on this call do not take great heed of a heart rate of 72 versus 62, but the evidence would very strongly suggest that we need to get people's heart rates down to near 60 with that. Then, of course, there was spironolactone used in a sicker patient population. This is the RALS trial from many years ago. Here, the mortality reduction is 30%. So all of a sudden, we have 3 cornerstone therapies: heart rate reduction with metoprolol or other beta blockers. We have ACE inhibitor, ARNI, or ARB, and the mineralocorticoid receptors like this particular drug. And what this showed was if you look at the mortality reduction and you add an ACE inhibitor or an ARB on top of placebo versus an ARNI, you can see the ARNI does better. You add a beta blocker on top of conventional therapy, you get additional mortality reduction. You add spironolactone or eplerenone, you get additional reduction. And hence this triad was considered to be cornerstones of therapy and that everybody should aspire, if they have a low EF heart failure patient, to be on those 3 drugs. But what changed that in the last year was the realization that there still is more benefit to be gained. And this came out of an analysis of a drug that was originally used to treat diabetes. This actually, believe it or not, came from an 1835 article that showed that apples, actually the root bark of the apple tree, improved urine output. And they didn't understand back then that's because you could spill glucose because you blocked a pathway for glucose reuptake, and that's what the SGLT2 receptor or pathway does in the kidney. And hence these drugs, of course, came to market, the SGLT2 inhibitors, as drugs to treat hyperglycemia. But remarkably, because of safety studies mandated by the FDA, analyses were done to say, did these drugs, because some diabetes drugs harmed people, did these drugs help cardiovascular or hinder cardiovascular outcomes? And rather remarkably, in these diabetes, these are all diabetes trials meant to lower blood sugar. But you can see from the line of unity that for cardiovascular outcomes, it appeared that these drugs, to the surprise of everyone, benefited cardiovascular outcomes. And the one that most benefit, here's a meta-analysis of 38,000 randomized patients in double-blind controlled trials, and both the kidneys and hospitalization for heart failure, as well as cardiovascular death, were dramatically improved if a diabetic was randomly assigned to receive an SGLT2 inhibitor versus a placebo matching for the SGLT2 inhibitor. This came out of left field. Nobody expected this, but it really galvanized people into doing additional studies. And in fact, additional studies were done. Here are a bunch of different drugs, 4 different SGLT2 inhibitors looking at cardiovascular outcomes, and look at the benefit of these particular trials. And these included individuals with atherosclerotic disease, included individuals with heart failure in the setting of diabetes, such that now studies were done where they actually looked at non-diabetics, and lo and behold, the same benefit was demonstrable in non-diabetics. In red is conventional therapy. This included triple therapy in the majority of individuals. And in blue, that therapy plus the SGLT2 inhibitor. And what you see in this trial is that there was a dramatic reduction, even in non-diabetics. So this drug had nothing to do with controlling glucose or causing glycosuria in terms of improving the outcome of patients with heart failure. And this was true of several drugs. Here are 2 of them. One is empagliflozin, the other is dapagliflozin, and the upper bar numbers are non-diabetics, the lower ones are diabetics, and you can see that the data points are comparable. So whether you have diabetes or not, in reduced ejection fraction heart failure, it was clear that there was a dramatic improvement in outcomes over a period of time using an SGLT2 inhibitor on top of conventional therapy. And this was even true of kidney disease. Look on the right, in blue are diabetics, in orange are non-diabetics. Two different trials looking at reduced ejection fraction. On the right, preservation of kidneys. So the heart is better, the kidneys are better, whether you have diabetes, whether you don't have diabetes, SGLT2 inhibitors were important. And lo and behold, that proved to be true in the heart failure syndrome, even if you had an ejection fraction that was not historically labeled as being low. Here is the preserved ejection fraction heart failure trial with an ejection fraction of at least 40%, or greater than 40%, I should say, and empagliflozin had a similar thing over the next 2 years of follow-up. So how can it be that SGLT2 inhibitors, if you understand this slide, you need a life, because this is what some people have said is the mechanism of action. And just notice that the SGLT2 inhibitor has lots of both membrane and intracellular effects. But if you look at why this drug works, and this is important for us to determine how do we position this drug. Some people said, well, it must work because it increases urine output and therefore reduces plasma volume. Turns out it doesn't reduce plasma volume. It increases over on the left here. Somebody said, well, it increases hemoglobin. It does that, but you can increase hemoglobin with erythropoietin and harm heart failure patients. It turns out that probably the way that these drugs work are by increasing the improving the metabolism of the myocardium and setting. There are two areas here. One on the upper left, that you in the heart failure state, the myocardium is calcium overloaded. And it turns out that SGLT2 inhibitors reduce calcium overload intracellularly in the myocardium. The other thing they do on the right is they increase ketones in the body. And you may have read recent data that administering ketone bodies actually improves cardiac performance because the heart switches to using ketones as its fuel source. So we now have two molecular mechanisms of direct cardiac action: less myocardial calcium overload, improved myocardial energetics. And this may be why, if you have the heart failure syndrome, regardless of your ejection fraction, that you will improve with SGLT2 inhibitors. And that's why now SGLT2 inhibitors are considered standards of care. And some of you are at Providence facilities. Next year, our quality metric for following heart failure in the Providence system will be the uptake of SGLT2 inhibitors for patients with heart failure. SGLT2/1 inhibitors are out there, and we'll see if they add anything. They reduce glucose uptake in the gut. So how do we prioritize which drugs to use? We now have 4 documented cornerstones of therapy. We don't know. Can we prioritize? I would say we don't have a degree of scientific certainty about how to do this, frankly. Maybe with the exception of beta blockers in patients with atrial fibrillation or beta blockers in patients with truly normal ejection fractions. But here's the paradigm. So initially you reduce volume overload with diuretics, and then you initiate the disease modifying therapy with these 4 pillars in 2022. Beta blockers, as I said, at least in sinus rhythm, sacubitril valsartan combination, spironolactone or eplerenone, perhaps finerenone in the future, and an SGLT2 inhibitor. The good thing about SGLT2 inhibitors of all these, it's the only one that doesn't really affect potassium levels. It saves kidneys. So these are the 4 cornerstones. How do you prioritize? I'll tell you that we can ask about that in the Q&A section, but honestly, we just don't know. And that's why we recommend that all of these be given. In our institution, once somebody is relatively euvolemic, they're started on all 4 in the hospital if they have new heart failure. Otherwise, all 4 within the first week with rapid up titration. Why is that? It's because the benefit of the SGLT2 inhibitors begins to appear within day 3. And by 2 weeks, you already have a statistical benefit, which is just phenomenal. So these have galvanized us to acutely treat the chronic heart failure syndrome. And thank you for your attention. I look forward to your questions in the Q&A session.
Thank you, Dr. Wright, for that amazing discussion of these optimal medical therapies. With that being said, we're going to go to our next topic by Dr. Marin. He did his residency at Washington University, Barnes Jewish Hospital, and cardiology fellowship at Tufts Medical Center. He's currently the director of Hypertrophic Cardiomyopathy Center, and he's a co-director of cardiac CT and MRI.
Great. Can you hear me okay?
Great.
Okay, good. Thank you. Appreciate the opportunity. I'm going to talk briefly about the emerging novel therapy of myosin inhibitors for HCM. I want to start first here, though, with understanding the mechanism that's responsible for limiting heart failure symptoms in the majority of patients with hypertrophic cardiomyopathy. That, of course, is outflow tract obstruction. Here's a still frame parasternal long axis view showing you the acute bend of the anterior leaflet making contact with the septum, creating impedance to the left ventricular outflow and the generation of very high LV systolic pressures as well as associated mitral regurgitation. So this is responsible. This is the mechanism of subaortic obstruction in HCM. It's the mechanism that drives the majority of limiting symptoms in this disease. It's a very mechanical form of heart failure. And so when we talk about what really constitutes the unmet need, treatment need in obstructive HCM, I wanted to talk about that first before introducing the new therapy. 70%, the majority of patients with HCM have outflow tract obstruction, either at rest or with provocation. And potential opportunities for unmet need are additional medical therapy for the 40% or so of patients that are kind of class 2 with obstruction, who could feel potentially better in terms of improvement in symptoms despite current therapies of beta blocker, calcium channel blocker, or the negative inotropic agent Norpace. And of course, there's the opportunity as well to potentially mitigate the transformation of these class 2 patients to more advanced heart failure symptoms. And therefore, if we had an agent to do that, we could potentially delay or potentially even eliminate the need for invasive septal reduction therapy for some patients with obstructive HCM. So this is the unmet need that we currently have for the disease. The myosin inhibitors, what are they? There's two drugs currently. Mavacamten's the first generation myosin inhibitor. Aficamten's the second generation. Mavacamten just completed a phase 3 study. I'm going to talk about it in a minute. Neither of these two myosin inhibitor drugs are at this point in time FDA approved at all. They work by binding to the myosin head and therefore decrease the number of myosin actin interactions. That translates into essentially a decrease in the power stroke of contraction. They're negative inotropes. That's what these are. This is a negative inotropic drug. By decreasing myocardial contractility, you can lower the outflow gradient that way. And anything that can lower or eliminate the outflow gradient will translate into an improvement in symptoms. And that's why these drugs have been kind of rolled out initially for the treatment of symptomatic obstructive HCM. And so what do we know today about where we stand with this? Well, first is some phase 2 data I'm showing you from mavacamten from a couple years ago. And the mechanism of action of the drug actually translated into a real physiologic observation. You can see here that in symptomatic obstructive HCM patients treated with mavacamten, gradients were lowered in most cases quite significantly because of a lowering of systolic function. You can see baseline ejection fraction is hyperdynamic, average decrease in EF to about 55. So a pretty substantial decrease in ejection fraction in this phase 2 study. So in other words, concordance here between lowering of the gradient driven by lowering of ejection fraction. And that led to the idea that that could translate, as I said, into a kind of a clinical benefit in terms of improving heart failure. And this is the Explorer study that was just published a couple of months ago. This is a phase 3 study, 251 patients. You can see the average age, hyperdynamic EFs. These were symptomatic obstructive patients with gradients of 50 or more, as you can see. And all patients were on background therapy, a beta blocker or calcium channel blocker, but not Norpace. And they are randomized to placebo or mavacamten for a 30-week treatment period. I'll just mention, though, that with Explorer, it's important to note that the majority of patients, 3/4, were class 2 and 1/4 class 3. That's completely different or flipped compared to surgical myectomy or alcohol septal ablation studies in obstructive HCM patients, where the majority are class 3 or 4 and the minority class 2. So this is a much less symptomatic group that had been previously studied with obstructive HCM. And here was the endpoint for the Explorer study, was basically an improvement functionally in CPEP or peak VO2 and improvement in subjective measure of heart failure by NYHA class, or a more or larger improvement in functional capacity by peak VO2, and no worsening in that endpoint in heart failure. So this was the function feel endpoint of Explorer. And over a 30-week period, about a third of patients on mavacamten met that endpoint, and 2/3 did not. If you take a kind of a little bit of a deeper dive in terms of symptomatic improvement, focusing on that alone, NYHA class, this is what happened in terms of the 128 patients on mavacamten. About 50% over the 30-week period have had a one or more improvement in NYHA class, which is good. So most of those patients, as I said, were patients that were going from class 2 to 1. We have really no understanding about whether any patients went from class 3 to 1 in Explorer. That information was not available, but about a 50% improvement in symptoms in patients on mavacamten. And the other half of patients on mavacamten, the other 50% at the end of the 30-week period, still remain with class 2 or 3 NYHA class limiting symptoms. So there's still a lot that sort of remains uncertain today about mavacamten, and we're limited, of course, in how much we can really extrapolate about the potential role of this drug if it is eventually FDA approved. And those include, but not limited to, these questions, for which the answer to one or more of them, as we, and hopefully some of those answers will come with obviously more time, but the answer to one or more of these questions could really dramatically impact kind of how we view the myosin inhibitor drugs in terms of efficacy and safety for treatment of symptomatic obstructive HCM. And just to kind of take a look at a few of these, how does mavacamten compare to the current treatments for obstruction? Of course, we have no head-to-head comparisons of mavacamten to surgery or alcohol ablation, or for that matter, to the other strong negative inotropic drug, Norpace. But what Steve Amon at Mayo and I did recently in a commentary was to put together historic data as a comparison to mavacamten. And what we're showing you here are the percent of patients after treatment across a number of drugs and procedures for obstructive HCM, the percent of patients that had residual outflow gradients of 30 millimeters of mercury or more. And obviously at one end, beta blockers are weak negative inotropes, and the majority of patients still have obstruction after beta blockers. That's why they're largely not that effective long-term in decreasing symptom burden. And at the other hand, you have surgery, which in experienced centers can directly alter the anatomy here in a way to completely alleviate outflow gradients. In fact, our goal is always to leave the operating room with no gradient after myectomy. And in the middle is mavacamten, where about a quarter of patients still had gradients of 50 millimeters of mercury or more after the 30-week treatment period. So you still have patients with residual gradients, significance of which is unclear. It could be responsible for some of those patients why they still had heart failure symptoms, and also could be responsible over time in generating recurrent symptoms in patients with residual gradients as well. We'll have to see as more information and longer term follow-up becomes more available. One question, though, is what kind of explains this difference in residual gradients between a drug, mavacamten, a negative inotropic drug, and myectomy, as an example on one end? And I just want to make the point here that this form of heart failure in obstructive HCM, as I said in the beginning, is a very mechanically based form of heart failure, meaning that it's due to the mitral valve, the abnormal motion of the mitral valve that's contributed to by abnormal papillary muscles and chordal connections, and the narrowed outflow tract generated by the hypertrophy. And so they got all kinds of anatomical issues that contribute to the obstruction. And therefore, it's probably going to be true that no drug is going to be able to completely eliminate outflow gradients sufficiently in all patients. And so I think that what you're sort of seeing with the early mavacamten experience is that there's going to be a proportion of obstructive HCM patients in whom the anatomy here, the outflow tract, is really important and really makes it maybe simply not amenable to the optimal lowering of gradient solely with drug therapy, even with a drug like mavacamten, which is the most potent negative inotropic drug we have to date for treatment of obstructive HCM. Also, the short-term response that we're sort of seeing in some patients with the Explorer trial translate into long-term efficacy. Remember, the average age at which a symptomatic obstructive HCM patient becomes a candidate for therapy is usually mid-40s, a lot younger than non-HCM forms of heart failure. So you're talking about younger patients, much longer treatment periods. And so long-term efficacy is so important here for that reason. And although we don't know the answer to that question, we do have some potential insights that were gained from the disopyramide experience in HCM. Again, disopyramide is an antiarrhythmic, but it's used in obstructive HCM because it's a negative inotrope. Again, negative inotrope, decreasing contractility to lower gradients here. And what we see here from the disopyramide experience is that about half of the patients can have a symptomatic benefit from outflow gradient lowering for many, many, many years. But about half of them get an improvement initially, but then develop recurrent symptoms because they still have suboptimal relief of the gradient with Norpace. And those patients develop recurrent heart failure symptoms again, and then go on to need septal reduction therapy. And so the jury's out about whether this, of course, will be the case with mavacamten as well, that the initial benefit doesn't translate into all those patients achieving a longer term benefit. Again, something we're going to have to kind of keep a close eye on as well. Some other issues have to do with other longer term issues with this drug. And I'll just point to you that the Explorer trial with mavacamten required 2 echocardiographic imaging visits where, based on the patient's ejection fraction and gradient, decisions were made to either up titrate the dose of mavacamten or even down titrate if the EF was too low. And so there were really important kind of safety and efficacy decisions being made in this very controlled, expert clinical phase 3 trial based on kind of expert interpretation of echo reading. And so that kind of raises the question, well, first of all, let me tell you that even with it, so because of that, even within that kind of phase 3 clinical trial, expert reader environment, this is what happened to ejection fractions with mavacamten in the Explorer trial, about on average, a 4% decrease in EF. So some decrease on average, but there were about 7% of patients who had much greater decreases in ejection fraction than the vast majority of other patients. These were super responders in a way because their EFs went below 50%. Now, of course, in non-HCM situations, below 50% or around 50% may not be as eye-catching as it is in HCM, where you're starting with, in this disease, of course, hyperdynamic ventricles where ejection fraction is often at baseline 60, 65, 70%. So these are really absolute decreases in EF that are quite dramatic, and include patients that went to EFs as low as 35%. Now, that was caught obviously because of the regimen of the clinical trial with these very frequent echoes, and as a result, the EFs were reversible upon stopping the drug. Also mentioned that there were 2 patients as well who developed Takotsubo syndrome, who got pretty sick, who both were on mavacamten as well. The significance of that is unclear at this point, but it's of note and certainly something to again watch closely as well as the general lowering EF issue. And so kind of putting all this together just in terms of EF, the very powerful negative inotropic effects of this drug, the need for echoes, I'll say this, that the reliance on longitudinal echoes to determine dosing for safety and efficacy, and the need for close clinical follow-up to detect these low EF patients really kind of raises one question about how well this clinical trial experience can translate into the real world clinical environment. Of course, we don't know the answer to that question, but I think because of the complexities of the disease, the complexities of the drug, the necessity for imaging follow-up here, that's an important question and one that we need to really be careful with as these drugs potentially get rolled out into clinical approval. Also, I'll end by perhaps the biggest potential challenge here, which is cost, probably going to be cost. We don't know the cost yet for mavacamten because that's not publicly available yet. Again, it's not FDA approved, but there are health economists who have weighed in, and I think a reasonable and potentially conservative cost estimate for this drug is going to be about $75,000 a year or more. And if you consider for a minute that the average age at which a HCM patient becomes symptomatic enough for a drug like mavacamten, again, about mid-40s, you're talking about on average 35 years that a patient would need to be on mavacamten to continue to suppress the gradient to feel better. Sometimes that may be longer. If you got a patient who's in their 20s or 30s with symptomatic obstructive HCM, you could be looking at 40, 50 years on the drug. But if you just take an average of 35 years, you're talking about a single HCM patient in whose cost for mavacamten, at least based on this current estimate, would be about $2.5 million. $2.5 million for a single patient. And if you compare that to the currently available invasive septal reduction therapy, myectomy or alcohol ablation, with one-time interventions, in whom the efficacy of these procedures, as I showed you, is pretty similar, if not better, maybe potentially, than the short-term information we have on mavacamten, you're looking at a price differential here that is staggering, to say the least. And so this is raising already a lot of antennas particularly in the HCM community about how to best, kind of start to think about this. What can we do to help mitigate this kind of cost differential? And so that we don't get into a situation where the drug is so expensive that for those that it would be good for, if it was FDA approved, it cannot be accessed because it is price or cost prohibitive. What does the future hold? It's very difficult always to answer that question, but particularly here with a complex disease, a complex drug, it's difficult to really, give you the exact answer. I don't think I know it, of course, but I will just summarize by just making the final couple points that these drugs, mavacamten, I did not talk about the second generation drug, aficamten, and I just didn't have time to do that, but myosin inhibitors decrease contractility, they decrease ejection fraction. There's no question about that. They can lower gradients as a result of that, but perhaps not as much as alcohol ablation or myectomy. They have residual gradients associated with them. It's unclear the significance of that at this time. They do improve over short term. Again, the phase 3 study was 30 weeks. Heart failure in about half the patients, with the other half still were limited by class 2 or 3 symptoms. It's unclear the benefit of the myosin inhibitor drugs in class 3 patients because there was no information available in the Explorer trial about whether any of the class 3 patients got a benefit that would be similar to that's achieved with myectomy. They appear safe, but longer-term data is needed, particularly the implications of chronic suppression of myocardial contractility, and of course, this issue that I raised about the acute decrease in ejection fraction in patients that are subjected to that, of which there were about 7% in the Explorer trial. If FDA approved, they may represent another medical therapy option for symptomatic obstructive HCM, but I do think that decision-making here will be complex and will often need and require the consideration of many factors, as well as, of course, shared decision-making with patients in terms of other options that are available today that are very effective at improving symptoms in patients permanently with this disease with low risk, like myectomy or alcohol ablation. So I'll stop there. I want to thank you for your time, and I'm happy to answer any questions during the question and answer period. Thank you very much. I appreciate it.
Thank you, Dr. Marin, for that excellent presentation. With that being said, we go to our next topic, which is being presented by Dr. Beacom Buskart regarding the universal definition and classification of heart failure. I'm so excited to be able to introduce her. A little bit background regarding her. She did her residency at Baylor College of Medicine in Houston and cardiology fellowship at University of Pittsburgh. She's the vice chair of medicine at Baylor College of Medicine. She holds multiple positions as a chair and director. And then, as we are all aware, she was the author of Universal Definition and Classification of Heart Failure. And she was also involved with the 2021 ACC/AHA key data element and definition for heart failure.
Thank you, Meyer, for that introduction, and thanks for the opportunity to be able to speak to the whole group. I really enjoyed the former presentations. So the title of my talk is the update in the heart failure definition and classification, which I will simplify as universal definition and stages of heart failure or UDHF. And these are my disclosures. And the universal definition of heart failure, as you alluded to, was a consensus statement between the Heart Failure Society of America, Heart Failure Association of the European Society of Cardiology, and the Japanese Heart Failure Society that was published early this year in March, simultaneously in the European Journal of Heart Failure and Journal of Cardiac Failure, and also endorsed by a variety of other international societies as seen on this slide, authored by 38 authors from 14 different countries. What we addressed in the universal definition was the overarching definition that was referred to by Dr. Wright, which is the syndrome definition that is critical to be understood and used by the clinicians at bedside as well as the researchers. Also, the classification for ejection fraction, which we use for targeting guideline-directed therapies, and then the stages of heart failure for our ability to be able to communicate with our patients and also focus on prevention as well as timely referral of our advanced heart failure patients. Starting with the overarching definition. This is a definition that is well known by all trainees, residents, and fellows. The textbook definition of heart failure, which is defined as a clinical syndrome caused by the inability of the heart to meet the metabolic demands of the body. And if we examine this definition, it actually is applicable only to a small percentage of patients. And this was represented by an elegant study by Doug Mann and his colleagues, where they measured lactate levels as a surrogate for tissue-level hyperperfusion in very advanced heart failure patients awaiting ventricular assist device insertion, and looked at the individuals with low cardiac index. As can be seen on this slide, a significant proportion of patients which had very low cardiac indices had normal lactate levels, and thus inability to meet the metabolic demands of the body probably is present in very advanced or terminal heart failure patients, but not in majority. And thus this textbook definition would not apply to most of our patients. And furthermore, if we examine the definitions that have been used in guidelines, they not only differed from the textbook definition, but they differed amongst themselves. Some focused on the symptoms and or signs, some on the hemodynamic characterization of low cardiac index and elevated filling pressures, some even on the neurohormonal characterization, which is not practically measurable in the majority of our patients at bedside. And if we examine what drives care, actually most of the care is driven by our administrative coding. As represented on this slide, ICD-10 codes represent a chaos of academic terminologies, hemodynamic characterization, and episodes of care. So we now have ICD-10 diagnoses that are systolic and diastolic combined, acute on chronic in terms of the episodes combined, and we don't have specific ICD-10 specifying causes of heart failure. And we also do not have any specific diagnostic criteria for stages of heart failure, identifying pre-heart failure or those at risk. Thus, our coding and documentation, which currently drives care, unfortunately falls quite short. And it also, when we look at what is happening in real world, despite the expanding evidence of guideline-directed therapies with numerous clinical trials demonstrating benefit with with standard agents such as ACE inhibitors or ARBs or beta blockade or MRA. The use of these agents in real-world population has not improved, actually has remained static, and in some you may even see some decline looking at the registries as represented on these slides over time. And creating a big concern as to why are we not able to increase, for example, the MRA use in indicated patients. And this slide represents the percentage of use among indicated patients, those without the contraindications, raising the question whether we're able to capture the right indications at the right time with the infrastructure that we have, emphasizing the necessity for us to utilize standardization for terminologies and maybe diagnostic criteria. And if we examine what has been implemented in research, research has traditionally used criterion-based approaches. And traditionally, either criteria such as Framingham criteria, and more recently in the last decade, clinical trials have required objective markers such as elevated natriuretic peptide levels or characterization of hospitalization. Thus, the objectivity that was able to be added on to the clinical symptomatology both enriched the trial populations, but also added specificity. And if we look at other disease states, most of the diseases currently are moving towards inclusion of an objective quantitative marker in definition. As we have seen with hemoglobin A1C in diabetes, or with eGFR in CKD, these criterion-based, quantitative marker-based definitions, though may have limitations, made the treatment targets and characterization of stages clearer for the clinicians beyond specialists. There have been suggestions for use of natriuretic peptides as the sole definition for heart failure, even in asymptomatic patients, as proposed by some colleagues, but these were countered by the recognition that natriuretic peptide levels by themselves may not be adequate because they are not specific. They tend to be elevated, especially in concomitant comorbidities such as chronic kidney disease or atrial fibrillation, and also with age. And the interperson variability would not be sensitive and or specific enough for us to be able to determine these variations between different episodes of times. And thus, the concept of sole reliance on a biomarker for diagnosis of heart failure at present time is not going to be adequate as it was with the universal definition of MI reliance on troponin. So with these in mind, we came up with a definition of the syndrome of heart failure as heart failure is a clinical syndrome with current or prior symptoms and or signs caused by a structural and or functional cardiac abnormality and corroborated by at least one of the following: elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion by diagnostic modalities such as imaging, or hemodynamic characterization at rest or with provocation. So the symptoms and signs, attributability to the heart, along with either elevated natriuretic peptide levels or evidence of congestion by imaging and or hemodynamics. The other area that we addressed was the stages. Why did we do that? It was clear that the stages of heart failure, though were understood by specialists, were not commonly utilized by non-specialists and were not understood by patients like cancer was, because the terminology we use as stages A, B, C, D gave the impression that all of these were heart failure, even though A and B were asymptomatic and were pre-heart failure, and thus created a concern to stigmatize the patient as heart failure in these pre-states. And also, in the historical tense, most of our treatment strategies focused on structural abnormality, LV dysfunction, for us to initiate therapies, but we now have ability to treat patients at a higher risk with recognition of biomarkers, especially in the pre-heart failure or stage B, specifically elevated natriuretic peptides and or cardiac troponin in the setting of exposure to cardiotoxins can identify a higher risk heart failure population, thus prompting specific treatment strategies. So with these approaches, we recognize the necessity of revision of the former ACC-AHA stages as the following. We propose use of at risk for heart failure for former stage A, which is for patients at risk for heart failure without current symptoms or signs, without structural, biomarker, or genetic markers of disease. Pre-heart failure for former stage B. These are patients without current or prior symptoms or signs of heart failure, but with evidence of either structural, functional heart disease, or elevated biomarkers such as natriuretic peptide levels or elevated cardiac troponin in the setting of exposure to cardiotoxic agents. Heart failure for former stage C. Patients with current and or prior symptoms and or signs caused by structural and or functional cardiac abnormality. And advanced heart failure for former stage D, for patients with severe symptoms and or signs of heart failure at risk with frequent hospitalizations requiring advanced therapies. We also emphasize that with treatment, patients can improve from advanced to heart failure state. And we would like to point out that in the universal definition, we actually acknowledge the concept that had been proposed by other colleagues for the definition of heart failure for asymptomatic patients with natriuretic peptide elevation. We had already incorporated this in our universal definition as pre-heart failure or stage B. We also in this document emphasize appropriate use of clinical trajectories, specifically use of persistent heart failure rather than stable heart failure for those patients with ongoing symptoms. Despite no worsening or improvement, these patients should not be termed as stable heart failure because that creates inertia or inaction, and also the false presumption of getting better by the patients. Similar to patients with cancer, active cancer, not being called stable cancer, we advocate not to use stable terminology, but rather persistent heart failure so that treatment can further be optimized. Also, we recommend use of heart failure in remission rather than recovered heart failure because even for those individuals with resolution of symptoms and or signs or with total normalization of EF, withdrawal of medical therapy can result in relapse in up to 40% of the patients, as was seen in the TREAD-HF trial. So in patients with heart failure in remission, guideline-directed therapies should be continued. And thus, rather than recovered heart failure, which can create erroneous discontinuation of therapy, we recommend use of heart failure in remission. In the universal definition, we also clarified classifications of ejection fraction and identified heart failure with reduced EF as EF less than or equal to 40%, mildly reduced EF as EF between 41 and 49%, preserved EF for EF equal to and greater than 50%, and heart failure with improved EF with baseline EF less than or equal to 40% with more than 10% increment from baseline and subsequent EF exceeding that of 40%. Why was this important? As we have heard from Dr. Wright, we do now have standard core therapies that are indicated in patients with heart failure with reduced EF, which now includes SGLT2 inhibitors, MRA, RAS inhibition with ACE inhibition or ARNI, as well as beta blockade. We also have evidence from both post-hoc analyses of studies with MRA, ARB, and ARNI, and the prospective clinical trial of Emperor Preserved with SGLT2 inhibitors, that these agents actually are also beneficial in patients with heart failure with mildly reduced EF as well as heart failure with reduced EF. So we now have the extension of therapies to incorporate all the way to mildly reduced EF. And when we look at Emperor Preserved trial, there was no heterogeneity in the primary endpoint of the combined endpoint of cardiovascular death and heart failure hospitalization according to EF classification. But interestingly, in the total heart failure hospitalization endpoint, there was heterogeneity implying there was benefit for EF less than 60%. So that creates the recognition that the benefit, the magnitude of benefit is higher the lower the EF is. With these in mind, the European Society of Cardiology most recent guidelines actually included ACE inhibitors, ARBs, beta blockade, MRA, and ARNI as class 2B recommendations for patients with mildly reduced EF. Keep in mind, the guidelines were published or released an hour before the release of the Emperor Preserve trial. Therefore, if we're to have been able to include the SGLT2 inhibitors, probably that those would have been able to be incorporated in this schema as a recommendation as an add-on in mildly reduced EF. Concepts about the discussion of ejection fraction. Ejection fraction has been a tool for implementation of guideline-directed therapy, not for definition of heart failure, the limitations of which are quite well known, and it has evolved as a standardization tool in guideline implementation and targeting guideline-directed therapies. With evolving trial results and design changes, we now have included mildly reduced EF in our classification. And these are phenotypic classification, not definition of heart failure, and the normal level varies, not only amongst genders, but according to loading conditions, according to hypertrophy, valvular abnormalities. Therefore, it's not a reliable classification for normal and non-normal, where there is not a single unique identifier to provide a cutoff level for normal. But the future probably will likely evolve into characterization of LV systolic dysfunction rather than just EF, if and only if we are able to come up with a practical, reproducible, widely available modality to characterize LV systolic dysfunction. Some concepts that come into mind, such as longitudinal strain, though has been applicable in most academic centers, is not widely available. And perhaps it could, as the phenotypic characterization evolves with wider use of EMR and diagnostic modalities, we could come up with a conglomerate of LV systolic dysfunction characterization with not only inclusion of reduced EF, mildly reduced EF, improved EF, along with abnormal global longitudinal strain, and maybe LV enlargement. The ESC 2021 ejection fraction classification actually is harmonized with the 2021 universal definition of heart failure and categorizes the EF into reduced EF, mildly reduced EF, as well as preserved EF. In the universal definition, we also emphasize treatment according to specific etiology, especially for entities listed on the right panel of this slide, which may require therapies beyond or in addition or in place of guideline-directed therapies such as amyloidosis or COVID-19 or Takotsubo or tachycardia-induced cardiomyopathies. And these need to be recognized as an etiology, and specific targeted treatment strategies need to be considered. So what should we be doing in the aftermath of the universal definition of heart failure? UDHF is going to be very helpful to diagnose, confirm, and document heart failure. I think subsequent to confirming the heart failure diagnosis, the clinicians should classify the phenotype according to ejection fraction and specify the stages to be able to initiate the guideline-directed therapies, not only solely for treatment of symptomatic heart failure, but also for prevention. Also, recognition of prognosis, ability to communicate with the patient, especially emphasize the pre-heart failure as well as heart failure. In the subsequent encounter, focus on the trajectory, use the terminology of persistent to optimize further rather than stable heart failure, which creates inertia or inaction. Use the terminology in remission rather than recovered heart failure to continue the GDMT. Reassess classification of EF if symptoms or signs change or indicated for new therapies. For EF, recognize that heart failure with reduced EF can get to the improved state, but not preserved. And preserved EF can remain as it is or may decline. Stages reclassification would be important for prognosis, for communication with the patient, as well as timely referral. We are working on the next steps following the UDHF to come up with standardization tools such as ICD-10 codes harmonized with the universal definition. And we're hoping that the registries, administrative databases, and research will follow the standard concepts that are introduced in the universal definition. So in summary, standardization of the heart failure syndrome as symptoms or signs caused by a structural or functional cardiac abnormality and corroborated by either elevated nitric peptide levels or evidence of congestion by diagnostic or modalities or hemodynamic characterization will enhance the appropriate diagnosis and optimization of GDMT and will help us achieve uniformity of care. The new revised stages classifications of heart failure as at risk, pre-heart failure, or advanced heart failure will be easier to understand by non-specialists as well as clinicians and patients, and clarify the treatment indications for pre-heart failure as well as heart failure. EF classifications as heart failure with reduced EF, mild reduced EF, preserved EF, and improved EF will help us standardize and clarify the treatment indications according to guidelines. And please recognize the emphasis for improved, not recovered EF, and the trajectory for persistent heart failure rather than stable heart failure, and heart failure in remission rather than recovered heart failure will allow us to optimize and not stop therapies inappropriately. Thank you for your attention.
Wow, thank you. That was incredible. I think we've all learned a lot, and I've seen many questions on the side. Just to follow up after that excellent talk, Beacom, I was wondering if you could speak a little about how to utilize this definition, perhaps in some of the things we're seeing now with these myopericarditis cases where there might be some fluid retention. Are we labeling these patients with heart failure? Would it be C, improved? And also, as we're getting better with our genetic understandings, are you using SAGE A or B for these patients who are genotype positive, phenotype negative for any of these things, be it HCM or channelopathies?
Pathogenic variants, especially detected in the individual itself, I think will allow us to call them as stage A or at risk. And of course, they need to be followed closely to be able to determine when and if they are going to develop the phenotype. And their family members, again, will be also the stage A. Those individuals with any structural abnormalities will be pre-heart failure. And of course, what to survey or screen them with will evolve as more probably precise, both microRNA and or other proteomics kinds of translational methodology evolves. Currently, with the universal definition, we came up with a general framework that is applicable to majority of the heart failure patients, but specific etiologies, I think, will require specific approaches that are beyond the stages and or the classifications we have created. Some of these genetic cardiomyopathies are going to be somewhere between pre-heart failure to all the way to structural abnormality to symptomatic if they were to be provoked. And I think these are critical for us to look at closely. In terms of myopericarditis, which I know is on a very important topic, especially in the setting of COVID and COVID vaccination and others, I think the overlap that we have in heart failure with a variety of other cardiac diagnoses, I'm going to look at the cardiac and also other comorbidities. We in the universal definition actually address this, where the proximity of the primary diagnosis, let's say myocardial infarction with heart failure, right? So if the proximal diagnosis to the presentation is the MI becomes a primary diagnosis complicated with heart failure. Pulmonary embolus complicated with RV failure and or shock, because if one were to look at that diagnosis, yes, the individuals may have dyspnea as well as may have elevated nitric peptide levels, but the proximal initial diagnosis was pulmonary embolus. So in those entities where we have a cardiac other diagnosis rather than the heart failure, which is an outcome of that diagnosis, we still remain within, especially during that acute phase, of the proximity of that initial diagnosis. So myopericarditis is an interesting concept. Let's assume it's only pericarditis, not myocarditis in that setting. The symptoms may be very similar to a heart failure, and yes, there may be abnormalities in the biomarker, and that will be probably an exclusion or an overlap that looks like or mimics heart failure but does not. So the other entities, comorbidities, CKD, end-stage kidney disease patients who miss a dialysis and come in florid pulmonary edema, or individuals with hypertension emergency. Yes, they do actually have evidence of elevated filling pressures, and actually hypertensive emergency will have heart failure. Definitely the cardiac contractility will be impaired, but let's just talk about the CKD. In that setting, it's volume overload. And those individuals we recognize may have elevation in their natriuretic peptide levels. Most of the CKD patients do, but those patients would not be heart failure. Though we recognize some of the kidney disease patients will have concomitant heart failure, and we do recognize it may be very much of a difficult one to separate these two entities. Some of them have concomitant. Some of them present with heart failure, but some of them actually have full resolution of their symptoms as soon as you dialyze them. So these are those individuals that we in the text address one by one. Adult congenital heart disease, valvular heart disease, pulmonary embolus, as well as CKD, obesity, all of those can have the overlap with heart failure or be complicated with heart failure or be without heart failure, even though they may have evidence of volume overload. I hope I answered your question.
That was great. We'll give you a moment. There are some great questions popping on the side for you. Dr. Wright, I was hoping, a lot of people are asking about where we might fit vericiguat and other emerging therapies. If you had a moment to speak to that.
Yeah, good question. And Marty actually alluded to this. One of the things that's going to face us is affording all these medicines. I mean, this is particularly true in the amyloid space. Oh my gosh, you want to put somebody on silencing therapy and stabilization therapy together, you're talking $700,000 a year for a lifetime disease. Vericiguat is not that expensive, but it's much more expensive than the agents we're talking about. So our current position is that if you use, and as you heard, the number of people using, if you look at guideline-directed therapy, if you look at all 4 classes at the doses that are targeted in the trials, only 3% of patients with reduced EF heart failure are on those doses today in the United States. So to me, rather than adding a 5th drug, the best thing to do is to use the drugs we know work. And I'm not saying vericiguat doesn't work, but a lot of people will have their EF go up and they'll become minimally symptomatic. And if they have an EF of 45% and they're minimally symptomatic, why would I want to add a drug that's thousands and thousands of dollars? It doesn't make sense to me. So I would argue that it has a role, but it's probably a niche role, and that we're underutilizing the drugs that we know work.
With that being said, but you've still moved to make it a goal for your institution to get people on the SGLT2 inhibitors?
That's system-wide, all 51 hospitals, you included. So yes, that's our goal for next year. Now that Epic can track that. And of course, the beauty of the SGLT2 inhibitors, unlike all the other classes of pillar drugs, which there's dose escalations, and it's really hard to know what dose somebody's on and are they on target doses. With the SGLT2 inhibitors, there's milligrams of the, and so it's the same dose. And so this is more of a binary, are they or are they not, as opposed to are they on the appropriate dose of a beta blocker, an ACE inhibitor, an ARNI, an ARB, spironolactone, and eplerenone. So it's actually easier to track, and they're not that expensive. They're applicable broadly. So that's why we've chosen it as our system-wide heart failure quality metric for 2022.
Thank you. And Marty, I think we've seen a lot of questions populating, at least amongst the panelists here for you. I don't know if you want to speak on any of them. Some of them were speaking to earlier utilization for more of a primary prevention and the genotype positive, phenotype negative, or just earlier upstream.
Sure. Yeah, I mean, I think it's an attractive idea to treat earlier. I think what I said, at least to the chat box, was one that, for the vast majority of obstructive HCM patients, we know from now a couple of decades of experience that if you do wait to, wait in quotes, but I mean, if you wait until the guideline directed intervention of kind of class 3 refractory from drug therapy, that when you intervene then with surgery or alcohol ablation, those patients do really well at that point, which has always been that kind of argument that we don't necessarily, for the broad population, need to necessarily, intervene earlier in all patients, but there may be select patients to whom that is a different story. And I think it was mentioned by you or others that, that patients, for example, with left atriums that are big, that are having PAF, that you would want to, get rid of the gradient and maybe do a maze procedure there, invasive therapies earlier, pulmonary hypertension, really high gradients. There's select populations to which there is a growing argument for earlier intervention, which today is surgery or alcohol ablation. And in fact, that's reflected in the new guidelines, which said that, class 2 is a indication in those patients if they can get to an expert center to have those procedures done within those higher risk subgroups. So yes, there is that. We're already implementing that idea. Whether mavacamten will do that too, or could provide that kind of ability to alter natural history, is obviously completely unclear because we have just so limited data at this point. I would be hesitant to extrapolate mavacamten's use that way at the moment, as I would giving it to a genotype positive, phenotype negative patient. Of course, the idea of stopping disease development is hugely attractive, but I'll just throw out the idea that the vast majority of genotype positive, phenotype negative patients never develop clinical disease here, okay? And we don't know who does and who won't. So, giving a very powerful drug and the idea that it could potentially, imagine talking to parents about that in a 14-year-old kid, who's genotype. So it's really complicated, and we're just not anywhere near there yet for that conversation at all.
Marty, can I ask you, can you use the drugs in people that the sort of geriatric group with non-obstructive but significant hypertrophic cardiomyopathy who don't have amyloid? So somebody with a 2.5 centimeter septum who has true diastolic heart failure, what's the role of these negative inotropes in those people?
Yeah, and that was also a question as well in the chat too. So here's the answer: is that we have limited insight into that. There was a small phase 2 study with non-obstructive HCM patients just that fit the clinical profile that you just said for several weeks on mavacamten, and what we found was that biomarkers did come down significantly. It was kind of the same kind of story as HFpEF with other drugs that experience. So biomarkers came down quite dramatically. So there looked like there was an effect, some kind of effect by the drug there that could be good, but that did not translate into clinical benefit, either in a clear improvement in symptoms or improvement in functional capacity by peak VO2. That may be because it was just too small a study. We just didn't have the numbers or the long enough treatment period for that group to see a clinical benefit. Maybe it's that our endpoints in terms of assessing clinical benefit are not really on the mark for non-obstructive HCM. There's a whole slew of different reasons, but at the moment, there's no clear indication or evidence, I should say, that these drugs have a clinical benefit in non-obstructive, but that's an ongoing, it's going to be an ongoing initiative. There's going to be more work there for sure.
And is there any evidence of regression at all on those drugs?
Well, there's a small subset that was published after Explorer with MRI follow-up that showed that, in some patients on mavacamten, wall thickness decreased, left atrial size decreased, cavity size changed. So there were some evidence of remodeling with the drug. And I would be cautious there in translating that to equate to something that's necessarily good. I know that that kind of remodeling in other forms of heart failure is good, but in HCM, when we see remodeling, not with mavacamten, but in other ways with wall thinning and cavity dilatation and those kind of things, that's the end stage phase, that kind of remodeling, septal thinning, decontraction of wall thickness has not been a good thing in terms of clinical outcome. So the answer is that there's some evidence that those drugs may do that, but again, it's unclear, to what extent and how to interpret that yet at this point. It's gonna take this story for these drugs and this disease is going to take a long time to work itself out. It's just, that's just where we're at. It's a difficult disease to study. The numbers are limited, the endpoints are different. And so it's going to take a long time for clarity.
There has been incredible discussion. Dr. Bosgard, I was wondering if you could speak to the question. I've heard you talk on it before, but the word heart failure doesn't strike a great chord with many patients, particularly at the new diagnosis. But to some others' points, like Dr. Chang said, it does speak to the gravity of the diagnosis, acutely and long-term. Could you speak a little bit about the direction?
Sure. I think I totally embrace the idea of coming up with an alternative terminology that is not, that doesn't create the stigma of a failure. But of course, the changes that are required in infrastructure and then the whole community, both in science as well as in terms of practice globally, was not ready for us to transition into a myopathy with symptoms concept. We did address it, or we tried to have that discussion in the universal definition. And as I mentioned, we were partnering with a variety of international colleagues, and thus the whole spectrum of change of a terminology requires a huge rehaul of the existing the diagnostic criteria, the ICD-10 codes, and so forth. And we want to do it in a stepwise fashion, and we will probably get there. But on the other side of the coin, we also need to recognize that cancer had a bad stigma, but no longer does, right? And I think the dissemination of information as to how you can successfully prevent something and or treat something. I mean, we had a similar concept in myocardial infarction, so it doesn't have the same nuance that it used to have 20, 30, 40 years ago. And cancer is perceived differently, even though the name itself was pretty ominous in the old times. So it's not just a name and it's not just terminology. I think the problem is the heart failure as an entity was not known and is not known, still is not known. If you were to Google it, the number of hits you get from heart failure versus cancer is a derivative of the cancer hits, even though the prevalence is very comparable, especially in the high-risk populations. And thus, I think right now when we're introducing the new concept for the first time to our patients, we do have struggle with the message. And for that reason, we came up with these pre-terminologies or at risk to empower both the clinicians to state that it's preventable. So you just don't always drown like some of the marketing strategies try to focus on. So this is an entity that's preventable, treatable, and as long as one is followed closely with the right care coordination, can eventually be even treated. So I think from that perspective, yes, there will be a paradigm change as precision evolves, but for the time being, I think the infrastructure requires us to utilize that terminology.
That was a great example and discussion on reframing and supporting our patients. Thank you. And it is with sadness we need to end this session. If questions want to keep coming in the chat box as we move on to our next panel. Thank you.
Great.
And again,
thank you so much to the moderators and speakers. A wonderful heart failure session discussion. There's so much innovation in the area, and being a heart failure cardiologist myself, it's really close to my heart. In the interest of time, we're going to move on to the next session. We're going to skip the break. So last session for today is going to be on cardiovascular imaging and inflammatory heart disease. I'm Richard Chang here at the University of Washington, and my co-moderator first is going to be Dr. Aris Karatsakas. So I'll pass on to Aris to introduce the first speaker.
Thank you, Dr. Chang. I know we're short on time, so I'll do my best to introduce Dr. Huang very quickly. He received his MD from Albert Einstein College of Medicine in New York, followed by residency in internal medicine at Boston, as well as fellowship in cardiovascular disease at Stony Brook. He went on to complete additional training in advanced cardiovascular imaging at Houston Methodist Hospital prior to joining the University of Washington in 2018 as director of the Echo Lab at Harborview. He's one of our advanced cardiovascular imagers reading both cardiac CT and nuclear imaging, and he'll be talking to us today about multimodality imaging for inflammatory heart disease. So without further ado, Dr. Huang, please take it away.
Hello, everyone. Thank you so much for that introduction. Let me share my screen. Hopefully everyone can see this. My camera's not working, unfortunately. But all right, so thanks so much for having me speak here today. So I'll be discussing multimodality imaging for inflammatory heart disease. I have no disclosures. So I'm going to start off by giving a background on inflammatory cardiomyopathies. I will then discuss the use of echocardiography in diagnosing inflammatory heart disease, and followed by the use of advanced cardiac imaging, including cardiac magnetic resonance and nuclear imaging. And then I'll finish off by discussing COVID-19 myocarditis. So in terms of definitions, myocarditis is the inflammation of the myocardium. It can be categorized histologically by cell type and or pattern. And it includes giant cell myocarditis, granulomatous disease, including cardiac sarcoidosis, etc. And we also have a newer entity, immune checkpoint inhibitor myocarditis, which is the result of adverse effects of the intended release of T lymphocytes from their quiescent state. And it's from monoclonal antibodies to negative regulation receptors, including CTLA4, PD1, and PDL1. And the most common medications in this category are ipilimumab, nivolumab, and pembrolizumab. Then obviously we have COVID-19 myocarditis. So endomyocardial biopsy is a gold standard for diagnosing myocarditis, but it's not consistently performed. Reasons are twofold. It is an invasive procedure, so there are risks involved. And it's also variable in sensitivity. You only have a 20 to 30% diagnostic yield in patients with cardiac sarcoidosis, for example, because of its patchiness. And this is just a figure showing the catheter going into the IJ, and you have the forceps acquiring specimen, as you can see here. And you can see the specimen under the microscope here as well. But as you can see, even though you're acquiring multiple specimen, you can miss a significant portion of the myocardium. So that's why more recently, we've turned to cardiac imaging for diagnosis. And the initial imaging modality that we use is transthoracic echocardiography. And the reason why it's used initially is because it's portable and widely available and relatively not costly. The problem is the findings are non-specific, and so it has a limited role in identifying etiology. You have a wide spectrum of findings. For example, in patients with cardiac sarcoidosis, you can have normal to focal aneurysms, wall motion abnormalities in the non-coronary distribution, and thinning of the basal septum, as you can see here, all the way to dilated cardiomyopathy. So the following is an echo from a patient I take care of who has cardiac sarcoidosis. You can see akinesis of the basal septum and overall reduction in left ventricular systolic function. A newer imaging modality that we use is strain imaging, and global longitudinal strain is measured using speckle tracking echocardiography, or MRI. It's a more sensitive measure of systolic dysfunction than ejection fraction, and it's abnormal in acute myocarditis and persistent inflammation. So this is an example of a polar map of a patient with myocarditis, and the more negative the number, the more normal it is. And so these regions in the basal septum and the basal inferior wall are more abnormal because numbers are more positive. It's overall down as well, consistent with myocarditis, and not again in the coronary artery distribution. And we're also using advanced imaging for diagnosing myocarditis more and more these days. And it's typically obtained when inflammatory cardiomyopathy is suspected. And the two modalities that we use are cardiac magnetic resonance, or CMR, which allows us to assess tissue characterization. And for diagnosis, we use the Lake Louise criteria. We also have nuclear imaging, in particular positron emission tomography, or PET scanning. So CMR is a non-invasive gold standard for diagnosing myocarditis. It's very highly sensitive and specific, of about 80%. and it identifies the two diagnostic targets during acute myocardial inflammation. And they are edema and non-ischemic myocardial injury. And we use the Lake Louise criteria for that. And if 2 out of the 2 Lake Louise criteria are present, then we can diagnose myocardial inflammation. And we assess myocardial edema on MRI with T2 and non-ischemic myocardial injury with T1. So T2 are if you have high signal intensity on T2 weighted imaging or high T2 values, and T1 if you have high native T1, increased extracellular volume, or late gadolinium enhancement, or LGE. And in addition to the main criteria, other supportive criteria are pericarditis and systolic left ventricular dysfunction, both of which you can assess with cardiac MRI. So LGE in myocarditis, typically you see a classic epicardial pattern of enhancement, and it typically affects the lateral wall, as you can see in the short axis image on MRI and apical 3 chamber view. You can see basically this increased in LGE in the epicardium and the lateral wall here. And LGE positivity also predicts adverse outcomes. You have a higher risk of sudden death if you're LGE positive. This study in the past year looked at patients with normal EF, low ejection fraction, and positive and negative LGE. And it shows that the patients with the worst survival and worst outcomes are those with LV ejection fraction less than 40% and positive LGE. If you're comparing LGE to T2 imaging, LGE again identifies necrosis, so you're going to have higher specificity, whereas T2 imaging identifies edema, so it's more highly sensitive, and the accuracy is pretty much the same for both. So the next imaging modality that I'll discuss is positron emission tomography, or PET scanning. And we use a molecule called F18FDG, which is a glucose analog that can differentiate inflamed from normal myocardium. And the protocol is we have the patient go on a low carbohydrate diet, which shifts the metabolism of normal cardiac myocytes from glucose to fatty acid, and essentially suppresses FDG uptake in normal myocardium. FDG uptake will be seen in areas of inflammation, however, because these areas will have activated macrophages and higher metabolic rates. FDG PET and CMR provide complementary information. PET scanning provides information on inflammation, and CMR for scarring. There's no adequately powered studies that compare how accurate both modalities are, so they're complementary. The top left image shows the protocol that we use at the University of Washington. Again, we have the patient's NPO for 12 hours, after which we acquire rest perfusion images. We then inject FDG and have the uptake period of 90 minutes, followed by a heart and whole body FDG scan. And this figure over here shows how we classify the pathology of cardiac sarcoidosis with FDG and perfusion. So perfusion, normal is a donut shape, and you can see normal perfusion here. And again, normally with FDG suppression, you should have negative FDG uptake in the myocardium. With mild or early disease, you have a slight reduction in perfusion and some FDG uptake. With more moderate and progressive disease, you have again worsening perfusion and further uptake in FDG. And severe or fibrous disease, you have significant reduction in perfusion and not much FDG uptake. We call this burnt out cardiac sarcoidosis. A algorithm that we can use for advanced cardiac imaging are if a patient has suspected cardiac sarcoidosis, then we typically choose CMR first because it has fewer non-specific findings than PET scan. And if the study's positive or inconclusive, then we undergo PET scanning. And again, PET scanning has a benefit of whole body scan for FDG uptake. If the CMR is negative, but the clinical suspicion remains elevated, then you can undergo PET scanning. And PET is typically used to follow the disease progression, which I'll discuss in this case here. So we have a 77-year-old female with a history of pulmonary sarcoidosis with heart blocks and has a pacemaker and new cardiomyopathy. They had an unremarkable CMR in 2016, but because the clinical suspicion is still high, we had the patient undergo a PET scan in May of this year. So the top images are rest perfusion followed by FDG, and it repeats. And you can see in the rest perfusion scan, you have a significant reduction in perfusion in the basal to mid inferior wall here, with a corresponding increase in FDG uptake in this region in the inferior wall. You can see that in the vertical long axis image here as well, again with corresponding FDG uptake, consistent with moderate disease. So we started the patient on a prednisone 40 milligrams with taper, and we had a repeat FDG PET scan a couple of months ago. You can see while the perfusion abnormality persists, you have a reduction in FDG uptake. The signal is not quite as bright. So the patient did end up improving with the prednisone. So we continued the prednisone taper and we started methotrexate. And lastly, a discussion on COVID-19 myocarditis. Obviously, there haven't been that many studies because it's such a new pathology, but in a study of 25 patients with COVID-19 with symptoms and at least one cardiac or at least one marker of cardiac involvement, these patients were found to have impairment in LVEF and strain analysis. And while they had a high prevalence of myocardial edema on T2 imaging, they have a low prevalence of myocardial necrosis. Only 1 out of 25%, or 1 out of 25 patients had LGE. So it questions regarding the effects and the specificity of the findings, because while it's, a lot of patients had myocardial edema, it's a relatively non-specific finding. A possible workflow for CMR is if a patient comes in with COVID-19 and they have concerning symptoms for cardiac symptoms, including dyspnea, chest pain, and palpitations, we typically acquire an ECG, echocardiogram, and cardiac biomarkers. If these studies are abnormal and there's an indication for CMR, then we obtain a CMR. And these indications include ventricular dysfunction, myo and pericarditis, MI with non-obstructive coronary arteries, chest pain, acute MI, Takotsubo cardiomyopathy, etc. And if the CMR is abnormal, then we follow these patients up after 3 to 6 months. So in summary, myocarditis has a broad range of etiologies. Cardiac imaging plays a crucial role in diagnosing and following up myocarditis. And tissue characterization by CMR is key, especially T2, which indicates edema, in conjunction with LGE, which shows necrosis. And CMR and PET-CT provide complementary information, CMR for scar and fibrosis, and PET scanning for inflammation. That's all I have. Thank you very much. And feel free to email me and follow me on Twitter as well. Thank you.
Great. Thank you so much, Dr. Huang, for a nice overview on multimodality imaging. We'll save the questions for the end. So next, I have the privilege of introducing Dr. Ron Blankstein. He's on faculty at the Brigham and Women's. He's a true leader in the field of multimodality cardiac imaging and published many of the seminal papers on cardiac sarcoidosis, many of which we reference on a daily basis.
Thank you, Richard, very much. It's a true honor to be here. Thanks for the opportunity to join from the other side of the country. I will be talking about management of sarcoidosis, and fantastic talk, by the way, that we all heard. So thank you for that. This slide shows my disclosures. And for my brief talk today, I'll talk about when should we screen for cardiac sarcoidosis, the prevention of sudden cardiac death, and then the role of anti-inflammatory therapy. So we should screen for cardiac sarcoid, first of all, in patients who have known extracardiac disease, if they have signs or symptoms of disease. But this is something that we need to assess on a yearly basis. So every patient that has extracardiac sarcoid every year, we should ask them if they've had any episodes of palpitations, pre-syncope, syncope, lightheadedness. Obviously, mild palpitations are okay, but if someone has significant palpitation, that becomes important. And we should do a yearly EKG as well. So that should be every year. Folks often ask, what about echo? Should we use echo for screening? And I think the data really does not support that. I think the issue with echo is that among patients who have cardiac sarcoid, the sensitivity is rather low. It's around 30% when we compare it to advanced imaging as the gold reference standard. It is specific. So if you happen to do an echo and you see LV dysfunction, you see areas of aneurysms, you see that the basal septum is either thick or thin, obviously that would be very concerning, but a normal echo does not rule out sarcoid. So this is patients that have extracardiac sarcoid. We should ask them about that. But then the question is, when should we use advanced imaging? What Dr. Wang just showed us, the algorithm was when should we use MRI and PET? And now we should think about two groups of patients, the patients that have biopsy-proven extracardiac sarcoid, who now have a sign or a symptom, and we talked about what those are. So during that yearly screening, if anyone says yes to those signs or symptoms, they now should have an MRI. If they're able to get an MRI, that would be our first choice, as Dr. Wang just showed us. Now, what about patients who don't have a history of sarcoid? If they have unexplained AV block or unexplained VT, this is when we should think about sarcoid, particularly for AV block in younger individuals under the age of 60. Okay, so that's for screening. Now let's talk about sudden cardiac death. And I think one of the important things to know is that the manifestations of sarcoid, of course, include heart block and heart failure and arrhythmias, but sudden cardiac death, at least in this study from Finland, was the third most common manifestation or presenting manifestation. And in fact, the most common mode of death was sudden death, where 80% of individuals who died from sarcoid died from sudden death. So this is really important for all of us to know. Now, this is Finland, this data, and you can say, well, what about the US? Do we have any data in the US? And we really don't have great national data, but recently a study did come out, which I thought was interesting. This is a study that was just published in JACC EP. This is from the National Inpatient Sample, so it only includes individuals who get admitted to a hospital. So it doesn't have the folks that many of us treat in the outpatient. And in over 800,000 individuals, the rate of sudden cardiac arrest was 0.5%. And in this database, it's hard to know exactly when that happened, but at least sometime during their course, they had sudden cardiac arrest. Interestingly, and not an insignificant number of these individuals were under the age of 40, reinforcing that we shouldn't be reassured by someone's young age. And also, amazingly, a very high proportion of individuals, at least by the administrative data that was used here, which I think is always a limitation, but a significant number of these individuals, normal LV function, reminding us what I think many people know is that you cannot be reassured with a normal EF if someone has sarcoid, and also of concern, a higher risk among African American. Now, if you look at the right side of this slide, one thing that I think is interesting is while the rate of systemic sarcoid in this data set was fairly constant over the time period of the study, there was an increase in cardiac sarcoid. And I often attribute this to the fact that maybe we're doing more imaging, both in Washington and in my state of Massachusetts. I think we do a lot of imaging for sarcoid. But one thing that would argue against this just being imaging is the fact that the actual rate of sudden cardiac arrest has seemed to increase as well, suggesting that this is not just us looking for sarcoid, but perhaps the rate of cardiac sarcoid truly is going up. So with that discussion of sudden cardiac death, obviously the only means today of preventing that that we know of is ICD. This slide here shows the ICD recommendation based on the 2017 AHA, ACC, HRS guidelines. Class 1 is sustained VT or an EF that's less than 35%. And there's many class 2A recommendations here, which I think are useful for us to consider. They include patients who have EF more than 35%, who have had syncope. And again, this table is specifically for patients with sarcoid. I think that's a nice thing about this guideline, is that they have a specific section on sarcoid, which actually was not present, I think, in older versions of some of these guidelines. If you have an EF more than 35%, and if you have scar by MRI or PET, that's also a 2A indication, as is the fact that if you have a high EF and you're going for a pacemaker, you might as well put it in the ICD in the same setting, or if you have inducible arrhythmia. So I think we have a whole group here of class 2A indications. And I think today in 2021, the majority of individuals that truly have cardiac sarcoid should be considered for ICD therapy. I know there's variability across institutions on this. In fact, variability across the world. I was recently giving a talk in Australia, and I was struck by the fact that they actually don't use ICDs quite as much as we do in the US. But nevertheless, you should know that patients who have cardiac sarcoid have the same rate of sudden cardiac death as many secondary prevention cohorts. So I think consideration of ICD is very, very important. Let's talk next about anti-inflammatory therapy. This is always a question, an area with a lot of questions, and I think there's a lot of uncertainties here. So first of all, what about the data about reducing inflammation? And today we have data that reducing inflammation is associated with an improvement in ejection fraction. And this data really comes from small retrospective studies, so none of this evidence is strong evidence. On the left side, a retrospective study from my own institution that we did a couple of years ago, where we followed individuals who had serial PET studies while they were treated with immunosuppressive therapy, most common steroids. And what we found as the amount of inflammation, which we quantified, or the intensity of inflammation, which we can also quantify, was a SUV max. As that went down, the ejection fraction improved. So small retrospective study. And recently in JACC imaging, another study, this one actually from a center in India, also with similar findings that as patients were treated and FTG went down, the ejection fraction improved. One of the interesting points here is that the patients who improved the most were those that had a greater intensity of inflammation, that's that SUV max, and had a higher number of segments with inflammation, i.e. FTG uptake, which are shown in the red color here. So at least this tells us that if we want to identify who are the individuals who are most likely to improve from therapy, it's those that are going to have the highest amount of inflammation on PET imaging. So I think that's an important data point. But let's step back and ask, well, what exactly is the benefit when we treat patients with immunosuppressive therapy? Obviously, these are very toxic therapies, and we have to know why are we even giving them to our patients. Well, I showed you now that perhaps we can experience improvement in ejection fraction. And we tend to see that more in patients with perhaps mild LV dysfunction. Once someone has a remodeled ventricle with severe LV dysfunction, I think the likelihood that they will improve is probably smaller. Perhaps there's also a role in preventing LV dysfunction if we treat patients who have a normal EF, who have a lot of inflammation, but this is speculative because I don't think there's good data on that. We do have data that the use of steroids is associated with an improvement in AV block. And the reason why I say associated is this is, again, all retrospective data. These are not prospective trials. We think that treatment prevents the formation of scar or fibrosis in the heart. And a lot of this we know from treating sarcoid in other organs of the body, even though in the heart, probably not. We don't have great studies to show this, but this is at least something that many of us believe. And finally, what about patients who have ventricular arrhythmias? Obviously very challenging to treat. We use antiarrhythmic therapies and sometimes catheter ablation, but the data on steroids to improve arrhythmias is rather mixed and probably no great data as far as we have today. So that's one that I think the data is equivocal. If we treat patients, the big questions are always what agents do we use? And still to date, the agents that are most commonly used is prednisone. The dose that we typically start is 40 to 60 milligrams. Some centers prefer a dose that's weight-based, In that case, you can use 0.5 to 1 milligram per kilogram. But lower doses may be reasonable. There are some centers that start lower doses than this. This is what we use in my own center. And we generally try to reduce the dose. We try to lower the dose by about 10 milligrams a month or so, ultimately to get to a dose of 5 to 10 milligrams over 1 year. And this is all assuming that we can observe a reduction in inflammation and an appropriate response to therapy with serial PET studies that we tend to do every 3 to 6 months. What about what happens at a year? At that point, we can keep patients on very low dose treatment, or if they're really not tolerating the treatment well, we can try to stop the therapy. The reason why we like to keep low dose therapy for at least a year or so is that there is a proportion of patients who are going to get worse, who are going to have a relapse after stopping therapy. So this is a challenging question. Who do you keep treating and for how long? My own practice is to keep patients on a very low dose, like 5 milligrams for a year after their scan is negative. Obviously, we use some shared decision making for that one. What about second line therapies? There's more of them that I've listed on this slide, but I've listed the ones that are most popular, which are methotrexate, mycophenolate, and azathioprine. Methotrexate sometimes added on top of prednisone to allow for lower doses, sometimes used as a single agent, even though no great data for doing that. So that's usually in patients who actually prefer to avoid prednisone and have a very strong preference not to be on prednisone, that we might try methotrexate as a standalone agent. And third line, partially because of the high cost, partially because of the risk of infection, and partially because they're not well tolerated once patients have heart failure, are TNF alpha antagonists. Multiple algorithms now that are being developed, and I just want to give credit to this review, and this was headed by Nisha Gilotra, Dr. Gilotra at Hopkins, and Dr. Farouk Sheikh. Fantastic review here showing an algorithm similar to what I showed you we do, which is to start patients on prednisone. In this algorithm, the doses are a little lower, 30 to 40 milligrams per day, potentially add a steroid sparing agent, and that allows you to use the lower dose of prednisone or not. And then 3 months later to do another FDG study to see if there's response to therapy, in which case you can keep the taper, or if the amount of inflammation seems to increase, in which case you have to think about whether to increase prednisone. And it's really important when you do that repeat PET study to quantify that. This is not just a visual assessment, and you have to do it on the same scanner, the same protocol. There's a lot of things that can fool folks to think that the amount of inflammation has increased when it hasn't. So I think there's a lot of technical elements beyond today's talk, but something to know that when you're using serial PET, it's not a it's a very tricky thing, and it has to be done in the same institution in the same protocol. On this slide here, I'm showing another algorithm, and this is a paper in press from my colleagues at Brigham and Women's Hospital. And here we show our algorithm that we typically start individuals on steroids, at times a lower dose of steroid with a methotrexate on top of it. And again, similar to the prior algorithm, we repeat the FDG scan in 3 to 6 months, and we use this information then to decide whether to go up on treatment, or hopefully if things are going in the right direction, which is usually the case, about 2/3 of the patients are going to have a good response or more. At that point, we taper therapy. So in conclusion, suspect sarcoid, at least cardiac sarcoid, in individuals who have extracardiac disease and now are having signs or symptoms of involvement. Also in patients who have new or unexplained heart block or VT. When patients do have sarcoid, PET is the only technique we have today to look for inflammation in the heart. And when we see inflammation, if there's a large amount of inflammation in the heart, if it is also present outside the heart, and Dr. Wang mentioned this, that we can use PET to look outside the heart, that's a compelling reason to treat. And obviously this is when we are certain of the diagnosis, or there's a high probability. With PET, there can sometimes be non-specific findings, and sometimes the diagnosis is not very clear. So we have to integrate data on the certainty of the diagnosis when we decide whether to treat or not. In patients who do have sarcoid, we should consider ICD. In a normal EF does not mean you are out of the woods. We actually see a significant number of patients with normal EF who can have arrhythmias, including sudden cardiac death. And obviously, the last point here, I think, is evident for anyone who's managing these patients, is this is really one of those conditions that you need a team approach: heart failure, EP, rheumatology, imaging, derm, pathology, in ophthalmology. So I can't think of any other condition in medicine where we truly need such a big team. With that, thank you all. Great to be here today.
Thank you so much, Dr. Blankstein, for your insights in this challenging and increasingly recognized pathology. I think in the interest of time, we'll move on to the next talk and tackle any remaining questions at the end of the session. So with that being said, it's a true pleasure to introduce Dr. Kapoor. Dr. Ruchi Kapoor received her MD and PhD from Cornell, where she focused her thesis on how drugs such as antidepressants affect membrane properties. She went on to complete residency in internal medicine and fellowship in cardiovascular disease at UC Irvine before joining UW in 2019. She has developed a keen interest in and expertise in cardio-oncology, as well as health advocacy and prevention, among other aspects of cardiology, and we're so fortunate to have her. She'll talk to us today about the link between inflammation and coronary artery disease. Dr. Kapoor, please take it away, and thank you.
Thanks so much, Aris, for that wonderful introduction. And I also want to thank the Washington ACC for inviting me to this, and hearty congratulations to Richard for the wonderful governorship coming up. So I'm going to take a little bit of a detour from the talks that we've had so far on cardiac sarcoidosis and imaging, and just talk about inflammation and coronary artery disease. I have no disclosures. And before we kind of talk about some of the trials that I think a lot of you already know about, where we've tried to tackle this problem, I'm going to go give a little background on pathogenesis of atherosclerosis and how it's really covered the landscape in terms of what we thought it was back in mid-19th century. Thought it was mainly an inflammatory reaction, and then there was a focus on thrombus. And then in early 20th century, really the focus went to lipids. And because we saw lipids in plaques and that it was primarily a cholesterol problem. However, in the late 20th century, 1970s, 1980s, there was then also a focus on smooth muscle, that there were these lesions that were primarily formed of smooth muscle proliferation. So it was a problem related to that. There was also discussion about it being shear forces that would denude endothelial. So it was an endothelial problem, and leading to maladaptive immune responses. And of course, you know, a lot of the discussion around these initially was, well, which one is it? Is it this or that? Of course, now we know that it's not one mutually exclusive hypothesis of concept of what atherosclerosis is, but it really is a synthesis of all of those ongoing issues, i.e. it is a very complex issue, but it means that we have a lot of different approaches to tackle the problem. To highlight kind of the different approaches, this I took from a wonderful review by Sondlein and Libby that was just published in August of 2021. And don't worry, I'm not going to go through all the pathways that are highlighted here. I'm not an immunologist, and I doubt I could, even if I wanted to. But a couple of things that I wanted to bring up is, you know, they highlight that that basically the cells that are involved in atherosclerosis, particularly looking at the inflammatory aspect of atherosclerosis. One is the smooth muscle cells, which have cholesterol uptake, which induces smooth muscle cell death. And these dying cells then release pro-inflammatory cytokines that including IL-6. The other aspect of inflammatory processes that are going on in these atheromas is cholesterol crystals and oxidized LDL rather than LDL itself, which tend to trigger the NF-kappa B pathway and promote the formation of this inflammasome, which is a complex of proteins. And this inflammasome then also triggers cytokine release and contributes to the atheroma formation. And the last cell that's involved here are platelets, and the same LPS, cholesterol crystals, oxidized lipids, they all activate or release neutrophil extracellular traps, the nets, which then activate platelets, which also promote assembly of this inflammasome, which again induces inflammatory pathways and cascades. So very complex interplay of different cell types, different types of immunity, thrombus formation into what goes into ultimately formation of atherosclerotic heart disease. I did want to take a slightly deeper look at the inflammasome and the pathway involved here. This NLRP3 inflammasome, it's come under recent focus, which you'll see why. But this is a multi-component assembly of proteins that senses a large variety of danger signals or inflammatory signals. And once this forms, it activates caspase, a proteinase that can cleave these pro-IL-1 beta and pro-IL-18 into the active forms of these proteins, of these cytokines. And IL-1 beta in particular can induce release of IL-6 from a whole variety of cell types. It's essentially an amplifier of pro-inflammatory signaling. And IL-6 in turn then triggers hepatocytes to produce acute phase reactants, including CRP. Now you kind of understand why I went through this in particular, because CRP, of course, is implicated in prediction of coronary artery disease. This is a prospective cohort study in Iceland. And what we see is that elevated CRP is predictive of coronary atherosclerosis, even after we take into account all the other common risk factors. This was also explored in the Prove It TIMI study by Ridker, where they were particularly focused on secondary prevention in people who already had underlying heart disease, but looking at this particular subpopulation in patients who had their lipids well controlled with LDL under 70, but had a CRP that was elevated greater than 2. Those individuals still had increased risk of recurrent MI or death from coronary causes compared to individuals who had normal CRP. So this led to the Jupiter study, where looking at the role of CRP in primary prevention. So these are individuals who don't have cardiac history, have LDL that's quote unquote normal under 130, but have elevated CRP. And these subjects were randomized to receiving high intensity statin Rezuva 20. And what we see is that rosuvastatin, of course, it reduces LDL, it reduced it by about 50%, but it also reduced CRP about 37% and had reduced cardiovascular events, including MI, strokes, revascularization for unstable angina, and death. So this was very promising that even with normal LDL, this benefit from CRP reduction was more than what they would expect with just a reduction in LDL. So going back to the inflammasome, the question was if we could develop a drug that targets really something along this pathway that blocks the release of CRP without affecting LDL, to really separate out the effects of rosuvastatin or statins in general on their lipids as opposed to their anti-inflammatory effects. And this is where the CANTOS trial comes into play. This is canakinumab, a human monoclonal antibody that targets interleukin-1 beta, which is this protein, this cytokine right here. And what we see here is that it really reduces, this is looking at 3 different doses, 50, 150, and 300 milligrams. And all 3 doses reduce CRP without having any appreciable effects on LDL levels. So we're really trying to tease apart this question of lipids versus inflammatory pathways. And the primary endpoint was non-fatal MI, stroke, or cardiovascular death. And we see that all 3 doses of canakinumab, 50, 150, 300 milligrams reduce it, but only 150 and 300 milligrams have significant effects in reduction of the primary endpoint. Furthermore, the 150 milligram dose met the secondary endpoint of unstable angina requiring revascularization. Unfortunately, this drug did show, this monoclonal antibody did have increased risk of fatal infections. So it wasn't really FDA approved, but this was the first proof of concept that if we target the inflammatory pathway by itself, then we may have some cardiovascular benefits. The next trial that was actually done somewhat in parallel with CANTOS was really looking at methotrexate, because methotrexate is readily available, already approved for a variety of rheumatologic issues. And here, rather than pre-specifying a CRP value, and really, rather than looking at primary prevention, they looked at secondary prevention in patients who had MI, multivessel CAD, but had increased inflammatory substrate in the form of diabetes or metabolic syndrome, and they were randomized to low-dose methotrexate. And as I mentioned, they didn't really pre-specify an elevated CRP level as an inclusion criteria. And what we see is that the low-dose methotrexate had no appreciable effects on CRP, on the interleukin-1 beta levels or interleukin-6, and it also didn't have any appreciable effects on LDL. And maybe not surprisingly, it didn't have any impact on the primary endpoint here. Of note, methotrexate is a, as I showed, doesn't really target any part of this specific IL-1 beta, IL-6 CRP pathway, but instead it is thought to have its anti-inflammatory effects through an adenosine-mediated pathway. The next kind of commonly available anti-inflammatory drug is colchicine. We use it very regularly in pericarditis. It actually, I don't know if anybody else knew this, but it comes from autumn crocus, has been around for centuries. And in this particular, the COLCUT trial, they again looked at secondary prevention in patients who had a MI, and within 30 days, randomizing them to 0.5 milligram of colchicine daily. Here, they did show that there was a reduction in reduction of cardiovascular events. And the effect was even more emphasized if the colchicine was given within 3 days of MI. The benefit wasn't as great if given after a 3-day time period. Colchicine works a little bit differently. It binds to tubulin, prevents microtubule polymerization, and it also reduces pro-inflammatory cytokine release. So the mechanism here fits a little bit more in line with what the CANTOS showed. Kind of building on the success of COLCUT and LODOCO, the trial number 1, which was an open label study. They did LODOCO 2, which was a prospective randomized trial where they looked at patients with chronic CAD that were randomized to 0.5 milligram colchicine daily, not really looking at MI per se. And what was interesting to me is how they defined CAD here. It was either by invasive angiography, but also coronary CT angiography and or a coronary calcium score of greater than 400. And this was also a positive study in that we showed 0.5 milligram of colchicine reduced cardiovascular events. And looking at some of this more secondary endpoints that included MIs, ischemia-driven revascularization, cardiovascular death, or ischemia-driven, unstable angina with revascularization. All of those were favored colchicine. And the couple more trials that I want to mention that are fairly early. One is going back to that inflammasome pathway. The question was, what if we targeted further downstream effects of the IL-1 beta, but upstream of CRP or other acute phase reactants, i.e. going directly for IL-6 inhibition. And this was just proof of concept that if we inhibit IL-6 with this human monoclonal antibody, it does reduce CRP levels. But pending further the remaining phases on whether it has an impact on cardiovascular outcomes or not. And then this is a very recent trial published earlier this year in JACC, a SAIL-MI, very small number of patients, which looked at tocilizumab, also inhibitor of IL-6 signaling, that showed that there was, it wasn't looking at cardiovascular events, but this was looking at MRI, cardiac MRI within 5 days of MI, of a STEMI, and seeing if there was any ischemic, the extent to which ischemic myocardium recovers. And here they show that tocilizumab patients who received it peri-procedurally had a little bit of a improvement in their myocardial salvage, not by a lot, about 6%, but the effect did exist. And looking at final infarct size in 6 months, the infarct size was slightly smaller, the extent of microvascular obstruction was lower, and the ultimate elevation in troponin T and CRP was also lower. So again, kind of proof of concept that maybe this IL-1 beta, IL-6 and CRP pathway is ripe for intervention. And this is kind of the last knowledge slide that I wanted to leave you with, which is again from that wonderful review article by Sondlein and Libby. They highlight a lot of the clinical trials that target the inflammatory pathways. And it's a little bit of a messy landscape because some of it is for primary prevention, some of it is for secondary prevention. And even in secondary prevention, it's looking at stable coronary disease versus acute MI when kind of the inflammatory milieu is at its peak. And so figuring out which of the population that would benefit most and which inflammatory pathway would be best targeted is a question that's still clearly up in the air, but a lot of exciting trials kind of en route. And then, and I just wanted to leave this, this actually came in the Seattle Times this morning. And I don't know if anybody else has had a patient ask for bacon flavored statins, but I have. And I've kind of now tried to tell patients that, oh, it doesn't just lower cholesterol, it also is an anti-inflammatory medication. And in some ways I've had more takers if I so to say sell statins that way. Thank you, and I'm open to questions. I don't know if we're going to do them now or later.
Great, thank you, Dr. Kapoor, for a wonderful talk. We'll do questions at the end. We have one more speaker. We have Dr. Tim Ball. He's a former flight surgeon for the Air Force and currently an interventional cardiologist at Providence Spokane. He's going to give us a talk on target lesion versus multiple vessel PCI and acute coronary syndrome.
Okay, are we good?
We can hear you. I think it'll be good to There should be a share screen button to share your slides.
Okay, hold on a minute. Thought I did that, but maybe not. Here and share. How about there?
Great.
We close?
Yes, we can see it now. And you might, you're in the standard slide mode. You should switch to Python. There we go. Great.
How about that? Okay.
Looks good.
Excellent. Okay, let's see. I think I am at the end. Oh, hold on. Accept my apology there. I don't know what happened, but all right. Thank you very much. Thanks for the organizers for putting this on and sliding me in late. Accept my apologies for missing my time window yesterday. But with that, I'll get on with my presentation of culprit lesion only versus complete revascularization in patients presenting with ST segment elevation myocardial infarction. I have no relevant financial disclosures to this talk or any talk really. Let's start off with a scenario which is common. Patient presents with chest pain, acute myocardial infarction, and we take them to the cath lab. PCI is performed, excellent angiographic result is obtained, ST segments resolve, patients improved, says, thanks, you guys are the greatest. And then like we see in up to 40% of patients, there's residual atherosclerotic coronary disease in non-infarct related arteries. What do we do? Some people would advocate that we press on and fix everything while we're there, like we do in non-STEMIs. Some people argue, why borrow trouble? Let's just let the dust settle and bring them back during the hospitalization or at a later time. Some people argue, let's don't do anything unless we prove ischemia. What should we do? That's what the focus of my talk is based on an evidence standpoint. In 2011, it was very easy. The ACC, AHA, SCAI guidelines was a class 3 for PCI on non-infarct related atherosclerotic disease. So it was simple. They did give a class 2B recommendation for patients in the treatment of non-infarct related atherosclerotic disease if there was demonstrated non-invasive testing ischemia. So there was a way to do PCI on non-culprit vessel or additional atherosclerotic disease, but it took time and then testing. This recommendation was based on a lot of observational data, registry data, meta-analysis data. And basically at that time, the feeling was that additional PCI in patients with STEMI presented a higher risk to patients, thus those recommendations. What I have done is looked at the data, and basically today we'll present only what I call primary data. That's the randomized trials that were large, that have been reviewed in other sites. I do not have any meta-analysis data presented today. The trials are seen here, and they have been published in journals such as New England Journal, JACC, Lancet, and I've laid them out in order of publication, and we'll discuss them all slightly individually. The first trial, which was published in New England Journal of Medicine, which is the PRAMI trial, Preventive Angioplasty and Acute Myocardial Infarction trial, was begun in the bare metal stent era. It's different than the others because 30 to 40% of patients were treated with bare metal stents in this trial. The culprit trial published in JACC in 2015 was different because it enrolled patients as soon as they presented with STEMI, whereas the other trials enrolled patients after successful culprit infarct-related artery PCI was done. The complete trial, the most recent, published in 2019, is the largest of the trials at 4,000 patients enrolled. And you can see overall that the enrollment numbers increased over time. So to break down these trials a little bit further, but compare and contrast side by side, I think it's important to look at the criteria for PCI. And in the PRAMI and the culprit trials, it was an angiographic lesion assessment rather than FFR-driven assessment. In the DYNAMI-3 compare acute and complete trials, it was FFR-guided assessment to determine which lesions in the multivessel PCI group should be treated with PCI. Timing, that's another question, and all the trials have some different takes on it, so that all the timing options have been studied, but differently. The PRAMI trial, PCI was mandated at the time of index PCI. Patient presented, infarct-related artery treated, randomization occurred. If you randomized to multivessel PCI, then PCI was performed at that time. In the culprit trial, it was recommended to perform complete revascularization at the time of index PCI. 66% of the time that happened, 34% of the time it was staged. The DYNAMI-3 specified that complete revascularization of non-infarct related arteries would be performed at 2 days after index presentation. The compare acute trial, again, a mixed trial, was suggested to perform PCI at the time of presentation. However, 17% of those were staged. And the complete trial, 100% were staged, but their staging was different. They said you can stage either within the hospitalization, the index hospitalization, which was approximately 1 to 2 days post initial presentation and STEMI treatment, or it could go out to 45 days post randomization. That would be a readmission PCI. So that's the variance in the different trials with respect to that. Looking at the individual trials and the primary endpoint, the primary endpoint for the PRAMI trial, which enrolled from 2008 to 2013, was a composite endpoint of cardiac death, non-fatal MI, refractory angina. I put the modality of death in the composite endpoint in red just because that varies between trials, just so you sort of, it catches one's eye. The primary outcome occurrence in culprit-only patients was 23%. The primary outcome in the multivessel PCI arm was 9%, highly statistically significant. And what I'd like to do is call your attention to the roughly 20% in the culprit-only PCI and the roughly 10% occurrence of the primary outcome in the multivessel PCI, because you'll see that starts to become a theme. In the culprit trial, enrolling in 5 centers in the United Kingdom between 2011 to 2013, primary composite endpoint, again, all-cause death, recurrent MI, CHF, ischemia-driven revascularization occurred in culprit-only patients 21%, and multivessel PCI 10%, highly statistically significant. In the DYNAMI-3 Primulti trial, enrolling patients from 2011 to 2014, 4 centers in Denmark, primary endpoint was all-cause mortality, non-fatal MI, ischemia-driven revascularization of the non-infarct related artery. We can see that the primary outcome in culprit-only PCI happened approximately 22% of the time. And in the multivessel PCI group, it happened approximately 13% of the time, highly statistically significant. And this trial utilized FFR guidance for revascularization in the multivessel arm. Also, this trial had, again, patients that were, the complete revascularization was performed 2 days post-index procedure. The Compare Acute trial was a larger trial, enrolling patients from 2011 to 2015 in Europe and Asia. Primary endpoint, again, very similar, all-cause mortality, non-fatal MI, revascularization. In this trial, they lumped in CVA as well. Their randomization was a little different. It was 1 to culprit, or SOS, it was 2 to culprit-only PCI, 1 to multivessel PCI. And their primary outcome was 20%, or occurred 20% of the time in culprit-only patients, whereas it occurred about 7.8% of the time in multivessel PCI. Highly statistically significant. Now, the largest trial is the COMPLETE trial. This trial enrolled patients from 2013 to 2017, 140 centers, 31 countries. It took a little interesting twist in that it utilized co-primary endpoints. So there was co-primary endpoint 1 and 2. Co-primary endpoint 1 was a composite of cardiovascular death and MI. Co-primary endpoint 2 was the sort of traditional composite endpoint, cardiovascular death, myocardial infarction, ischemia-driven revascularization. Patients were randomized 1-to-1 to either culprit only or FFR-guided multivessel PCI. Again, no acute, that was an exclusion for this trial. If you did multivessel PCI at the time, it was an exclusion. So they were either randomized to completion of revascularization within the index hospitalization, which occurred 68% of the time, or 32% of the time done within 45 days of randomization. Co-primary endpoint 1, that is cardiovascular death or myocardial infarction, occurred in 10.5% of patients in the culprit-only arm and 7.8% of patients in the multivessel PCI arm, highly statistically significant. So 3%, roughly 3% absolute risk reduction, which is pretty good in myocardial infarction and primary cardiovascular death metric. In the co-primary endpoint number 2 of composite cardiovascular death, myocardial infarction, ischemia-driven revascularization, culprit-only primary outcome composite 2 occurred 16.7% of the time, whereas in the multivessel arm, it occurred 8.9% of the time, highly statistically significant. These numbers then, I think, are important when you look at them all together from the culprit-only primary endpoints. The endpoints were fairly similar between the trials, but what you can see is the occurrence of the primary endpoints in the culprit-only arm, it hovers around 20%. Some might try to glean some sort of maybe reduction over time from 23 down to 16.7 with changes in how we do business, that is bivalrudin, changes in 2B3As, changes in new P2Y12 receptor antagonists, changes in stents, changes in polymers, changes in drug platform, changes in aspiration thrombectomy. Hard to say, but I just look at it as roughly, from a simple standpoint, about the primary endpoint occurred composite in about 20% of patients in all the trials, roughly. And then if you look at the composite endpoint occurring in the multivessel PCI arms, it was about 10% in all these trials. And all the trials showed highly statistically significant differences between the groups with respect to the composite endpoint. The complete trial did have as a co-primary endpoint the composite of cardiovascular death and myocardial infarction. None of the other trials had that. And if you look at the presentation of the data in the individual trials, there was no statistically significant difference in myocardial infarction or death in any of the trials other than PRAMI, the first trial, and the complete trials. So with that, what do we do with our patient who presents with MI treated and then has residual atherosclerotic disease? The ACC-AHA guidelines gives complete revascularization a 2B recommendation. That is, we can perform a complete revascularization. The 2017 European guidelines give a class 2A recommendation for complete revascularization. That is, it should be considered. And the timing is not specified because there is not adequate data on in trials to say when should we do it versus when shouldn't we do it. So I think that revascularization should be considered. If it is optimal to do it at the time of index PCI, the time of STEMI, we're there, it's one vessel, get it done, no problem. I think that's reasonable. I think if there's a reasonable reason or a good reason to say we should stop and let's hold and fix them later in the hospitalization, I think that's totally reasonable too and is supported by the guidelines and the data. I think that if we have PCI within the 45 days, that is, let them go home, let the dust settle, and bring them back, I think that is reasonable. I think that we must demonstrate ischemia with FFR before we proceed with PCI, not just angiographic. And I think that if patients have a real strong relative contraindication to coming back to the lab, I think that it is still reasonable to follow the 2011 2B recommendation, which is demonstrate ischemia prior to coming back to the cath lab. With that, I'll close and thank you.
Great, thank you so much for that talk, Dr. Ball. So let's have the speakers come back. So we're going to do the Q&A. I'm going to try to consolidate the questions in the interest of time to ask each speaker one question that provides an overview. So Dr. Huang, so one question is, what is the role of serial imaging in patients with inflammatory heart disease, and which modality would you recommend? Would you recommend echo, MRI, PET, or would you do all of them?
It's a great question, Richard. We typically do FDG PET to follow disease progression, especially in cardiac sarcoidosis. Echo is not as specific of a test as we need, and cardiac MRI is more used for to assess necrosis and fibrosis with LGE. So I typically use FDG PET.
That's great. Dr. Blankstein, it looks like there's a lot of questions about what to do with the patients with known systemic sarcoid without known cardiac disease. So some of the questions that came through are, for these types of patients, when would you consider an EP study if they don't have known cardiac involvement, as well as when would you consider cardiac imaging in these patients?
Yeah, no, a lot of good questions. I think for imaging, I think some of the questions I saw is, what about someone who has extracardiac sarcoid who's completely asymptomatic, normal EKG, no signs or symptoms, and that no good data to do imaging in those patients. The concern is you start doing imaging like an MRI, you see a little area of LGE, you do a PET, and you see some non-specific FDG uptake, and you're at some point more likely to have false positives that can trigger a lot of unnecessary events. So still the recommendation I would have is look for the signs and symptoms and be careful with using advanced imaging. Now, certainly if you're very concerned about someone, you could do an MRI, but I'd be very careful not to act on the results too much in someone who's asymptomatic normal EF, even if you see a small area of LGE, which sometimes is non-specific. We see that even in patients without sarcoid. I think the second question that you asked was about the role of EP testing. And that's once you've already made the diagnosis of sarcoid, perhaps an abnormal MRI or an abnormal PET, and you're on the fence of whether to offer an ICD. Maybe the EF is normal, but you see some scar by MRI. I think in those cases, there's definitely data that doing an EP study to try to provoke ventricular arrhythmias can help you and predict the higher risk of sudden cardiac death. So I think if there's uncertainty about the role of ICD, that's where we go to the EP lab. But by the time you're at that juncture, it's usually someone who already has some signs or symptoms. It's not going to be a totally asymptomatic person that you're sending for an EP study.
Great, thank you so much. Dr. Kapoor, it looks like there's a lot of questions regarding sort of the clinical uptake of colchicine and other anti-inflammatories. I'm curious why you think there's not much use of screening for inflammation or colchicine in general practice, and whether this has to do with needing to make it bacon flavored.
That would be a great way to get everybody to take their pills. I'm not sure. It's I would say, one thing that is certainly, as I mentioned in the chat box, certainly on an outpatient basis, I sometimes have trouble getting colchicine approved, even for like known indications, established indications like pericarditis. So I think there is certainly barriers from insurance companies on approving it based on one or two studies. And I think the jury still kind of feels like it's a little bit out. The benefit wasn't that dramatic. But I think the benefit was really dramatic in where certainly after MI within the first 3 days. So I think kind of my inclination would be to try and actually give it in the hospital after you see a MI patient and see if that kind of gets us a little bit more bang for the buck. But I don't quite have a good sense of why it hasn't been widely established or practiced. ACC is certainly behind it.
Thank you, Dr. Kapoor. I wanted to ask Dr. Ball, thank you again for your insights. What about CTOs, non-culprit CTOs? Do you think there's any role of vascularization there, especially given that we cannot employ physiology during the index procedure?
So that was addressed in some of the trials, and these trials did tackle CTOs. And so I think that CTO revascularization is part of complete revascularization. So if it is deemed a reasonable CTO target, then we should include it in staged revascularization.
Thank you.
Great, thank you everyone for such a great session and discussion. So that'll be the end of this session. I'm going to hand it back to Dr. Nayak, who's going to give presentation of the abstract awards for what was presented yesterday.
Yeah, thanks, Richard. I think actually Lane is going to do that while we wait for her to get on. I just wanted to put in a plug for November 16th at 5:30. Dr. Kapoor had a CV team talk she was going to do live earlier this summer that we had to cancel, but she's going to do it virtually. She's kind enough to do it virtually on November 16th at 5:30. So it's specific for CV team members. So get your CV team folks registered for that learning experience, but also obviously it's open to anybody that wants to come and learn about cardiac amyloidosis, which I know Richard is also very keen to discuss at times.
All right, so last but not least, I will announce our the winners from yesterday. So in the research category, the first place prize goes to Dr. Alex Taylor. So congratulations, Dr. Taylor. And then in our case presentation, the first place prize goes to Dr. Andrew Diaz. So congratulations, Dr. Diaz. As part of your first place prize, you'll receive $1,000 from the Washington ACC, and that will be able to be used towards an ACC event next year. So thank you for the ACC for this prize for our winners, and congratulations.
Awesome. Well, I again want to thank everyone for attending, all of our speakers and moderators. It was tremendous. Huge congratulations and thank you to Richard and Lane. You guys did an amazing job. And then, of course, none of this would have happened without Liana. Thank you, Liana, our chapter executive. Just all of your hard work over the last really 2 years doing this virtually. It's not easy. Appreciate everything you do. And so with that, we'll conclude this year's annual meeting. Thank you guys again. And we'll have the recordings online, and you'll be getting information about CME in the coming days so that you can claim the CME and the MOC points. Thank you, guys.